virtual galaxy of stars as the esteemed guests for tonight, and also a host of wonderful faculty who are all very well versed and they are stalwarts at their field. We also have our distinguished office bearers of Kasoga and Foxy, and most importantly, we have our eager, enthusiastic participants who are willing to, do their best to delve into the field of research methodology. So, before opening the meeting for further proceedings, let us begin by invoking the blessings of the Almighty with a prayer song. Arun sir, if you could please play.
Kurutvam kalyanam arogyam dhanasampadah Shubham kurutvam kalyanam arogyam dhanasampadah Shatrubuddhi vinashaya Deepajyotirnamostute Deepajyotirnamostute Shubham kurutvam kalyanam arogyam dhanasampadah Shubham kurutvam kalyanam arogyam dhanasampadah.
Thank you, Mr. Arun. So with those divine blessings, now let's start. And to take us through the proceedings of the evening, we have a young researcher herself, Dr. Shruti Bhavi Patil. She is the smart and dynamic president of the Gadag OBG Society, and she's also an executive committee member of Kasoga. Dr. Shruti, over to you for the further proceedings. Dr. Shruti? Is she there? I can't see her on the screen.
No, madam.
She's not here.
Shruti, are you there? Oh,
Shruti has
anyway,
dropped out.
you carry over.
Hello?
Geetanjali.
Yes, ma'am. So, Shruti, Shruti is back.
I want you to introduce Dr.
Shruti is back, madam. Yeah.
Hello.
Yes,
Mama.
Shruti. Welcome back.
Yeah. Since Jaideep sir is not there, we'll go ahead with introduction of this thing. ma'am. So
Yeah.
I invite everybody for this esteemed gathering. So can we have so I welcome our chief guest, Dr. Jaideep Tank, who will be joining later. I also welcome our guest of honor, our chief patron, Kasoga, Dr. M.G. Hiremat sir, and our beloved Kasoga president, Dr. Vidya Thobi madam. And also I welcome our chief special guest, Dr. Charmila ma'am, who will be also joining later. So I request Arun to play the CV of M.G. Hiremat sir. So I take this privilege and honor to introduce Dr. Professor M.G. Hiremat sir. He's the founder and president of Kasoga, founder secretary Kasoga and chief patron. And also currently he's the director of Hatch IVF Center, Matoshri Women's Hospital, Hubballi, and he was former director, Karnataka Institute of Medical Sciences, Hubballi. And he's the recipient of Millennium Fellow Award for Excellence in Academics by Foxy in 2000. He's also been a past Vice President Foxy and ex-Chairman Breast Committee Foxy. We welcome you, sir. Now, may I welcome Dr. Vidya Thobi, madam. She is currently President of Kasoga and also Professor of Al-Amin Medical College, Bijapur. She is Chairperson Food and Drugs Committee and also Medico-Surgical Equipment Committee Foxy 2018-2020. And she has won the award for Best Committee Foxy, Dr. Meheru Dara Ansoshe Award in 2020. She has also a lot of publications and she's invited faculty at many national and international conferences. We welcome you, ma'am.
Thank you. Thank you very much.
So I request Dr. M.G. Hiremat sir to please express his thoughts on this occasion.
Good evening to everybody. Respected chief guest of today's program, Dr. Jaideep Tank, special invitee, Dr. Charmila, and today's Clinical Research Committee, FOXI Chairperson, Dr. Surekha Taide, Kasoga Chairperson, Dr. Gitanjali, convener of today's program, Dr. Shruti Bhavi, and all the guest speakers of today's program and the invited delegates. At the outset, I am a very happy person today because our research committee has taken up the program today. For a long time, we were waiting for our program. Congratulations, Gitanjali, for arranging such a wonderful program.
Thank you,
That
sir.
in association with FOXI. As you know that FOXI is our parent body and we always love to be with FOXI and all FOXI Dians will be here. And you both of you have done such a wonderful thing that you have arranged so wonderful speakers. All are stars. 6 stars are there today and people can go with the 6 stars on their shoulder. If they sincerely attend today's program, the postgraduates are the most beneficial people today because these are very, very important, I personally feel. Now today is the era, gone those days, without a single paper, one could have become the professor, one could have become the associate professor. But today, at every stage, NMC is so particular that they need to have a research. More so in our Khair University, the vice chancellor is so keen that if you don't have a research paper, you will not get your promotion. That is the order from our vice chancellor. I think it is mandatory for everyone to have the research background, and you have involved all the such a research great people. Dr. M.B. Bella, Dr. Madhav Prasad, Dr. Surekha, Dr. Naina, who is a wonderful speaker and she is a wonderful trainer for NMC, all the NMC's academic activities from Belgavi, Dr. Manish, and so wonderful topics have been chosen. I think my MB Bella is a master choosing a research question because he has done so much of research work, which I have seen very closely because I was a faculty in Belgaum. Performing a literature search is also equally important, and choosing an appropriate study design is very, very necessary. And putting all together in a crisp manner, that is, Naina is very much expert in that. And Manish, basics of data analysis. I think this all what topics you have been covered. I think they give a really a good knowledge to every postgraduate. And from my bottom of heart, I congratulate both chairpersons, Dr. Surekha and Dr. Gitanjali, and our Vidya Thobbi, our president. So keen for all the activities. And
phone number code.
today I will really everybody, it is a feast of knowledge. So I wish a grand success for this program. Once again, I wish you best of luck, all the involved people. Thank you very much.
Thank you for your blessing, sir.
Thank you, sir. May I call Dr. Tobbi ma'am to speak a few words?
Thank you, Dr. Shruti, and very good evening to everyone. And thank you, Dr. Jaideep Tang, sir, because in his busy schedule, he will be joining us. And I congratulate Dr. Surekha Taide as well as Dr. Our Gitanjali. She has taken this task and she told me that, Madam, now synopsis submission is there for all the colleges. Let us take this research methodology workshop.
मॅडम मी थोड्या वेळाने कॉल करू का
Surekha, are you busy? You'll be here, no, for our this, no?
I'm here.
Yeah. So most of our participants today are today evening are the young first year postgraduates, right? So they are in the process of preparing their dissertation and synopsis, and maybe some of our consultants might be interested in the field of research because we know that now it is a evidence-based medicine, and some of them they want to publish the data. If they want to become ICOG member, they have to publish 2 publications. So it becomes very important for us to how this evidence is generated and how good evidence, that is also very important. So it all depends on the analysis of whatever personal experience, data collection, and how to interpret, and we have to, in our day-to-day practice, how to understand this, and the basics of research methodology today we are going to cover. And when we are submitting the synopsis, there are various practical tips how to go about it, what should be done, what should be avoided, what is the right thing to be done. This is very important. And all postgraduates, they think that submission of synopsis or carrying out this dissertation is really burden. But I think it should be a pleasure to take a research question and this research question how to implement in their journey of 3 years postgraduate. So this insight, I think today we are going to discuss with the various stalwarts. Today they are going to talk about it and how to submit this synopsis, what are the obstacles, all those things will be discussed and guided. The research is really research and there are various breakthroughs which come out through this research and we can publish. Actually, I just wanted to have our Kasoga journal and we are into it. We are going to do some ethical committee also. We tried through Gitanjali. I think Surekha also can join in. And for Karnataka state, at least consultant, they can also publish their data by taking the help of this ethical committee. We are going to have, of course, the journal every month, one journal club. That will also is going to help our postgraduates and consultant. And we are picking up some practical journal topics which will help for our consultant. Everybody loves to publish, but plagiarism is another thing. And we should always avoid, we should follow the rules. And there is also ethics of publication. So this is a very meaningful journey in research. I hope that this webinar is going to be very fruitful and fruitful academic session, and the speakers are excellent, as Hiremed sir told. He is always a guiding force for us. He himself has so many publications to his credit. So this CME is going to benefit both consultants as well as postgraduates. Of course, I am going to enjoy it. Thank you, Dr. Gitanjali and her whole team of research committee of Kasoga and Dr. Surekha, who had joined with the FOXY research committee. And I welcome Dr. Charmila also, who was a past research committee chair and at present she is a vice president, South Zone. So welcome Charmila and the whole team. And thank you very much for inviting me. I am there throughout to listen to you. So thank you very much.
Thank you very much, ma'am. Without much delay, we will introduce our first speaker for today, Dr.
Can I
Mrityunjay
just speak for a while, Dr. Shruti? I just wanted to
Yeah.
thank
Yes, ma'am.
the Kasoga team because
Yeah, addressed by
collaboration.
Surekha also.
Yes.
Yes.
Please address.
Yeah, I would just like to thank the Kasoga team because the collaboration with Kasoga has always been pleasant with the Dr. Vidya Thobi ma'am as the president. So, and we as a clinical research committee of FOXY has decided to collaborate on the journal club as well, and also some practical topics like respectful maternity care, which we are going to collaborate as a community. The hospital provider based training. So that also we are going to come up with this in the next few days. So collaborating with Kasoga and has been really very, very important for FOXY. And as you see, Dr. Jaideep Tank will also be joining us. So I would just like to thank all of you, all the stalwarts. I can see Dr. Bellar sir also is there. Dr. Hiremed is there. Vidya Thobi ma'am, Gitanjali has taken a lot of efforts, and definitely the speakers are quite the galaxy of stars, as you have said. So we do have all the practical topics here, and I wish all of us a successful event, and we are awaiting Dr. Jaideep. Till that time, I think we can start with the first session. Thank you very much, all of you.
Thank you so much, ma'am. I'm sure collaboration with FOXY and Kasoga will go a long way for Clinical Research Committee. So I would like to introduce our first speaker for today, Dr. Mrityunjay Ballat sir. He is professor and also my teacher from JNMC, Belgavi. So he is a very well-known and eminent person in the field of research. So he is a principal and co-investigator of many WHO projects, naming a few are CLIP trial, Cradle trial, Rapidron trial, and also he's a recipient of many awards, Best Scientist Award, the Newton Baba Team Award, and recipient of MS Signature International Award. So many credits to his personality. So we welcome you, sir.
Thank you, Shruti. I think with your permission, shall I go ahead sharing my screen?
Yes, sir.
I
I
hope
welcome Dr. Bharti Rajshekar, who I joined just now.
is my screen visible to everyone?
Yes, yes, yes.
Okay, that's fine. So
Good evening, sir. Sorry, I am operating, but I am listening to all of you speaking. I will join.
I think you
Yes,
can
sir.
give it to your assistant and join, madam. You
Sir,
have finished.
histoscopy, I will just finish in 5 minutes.
Thank you. I
Thank you.
just was joking. You can go proceed and
Sir,
finish.
audio.
But what we can learn from this is even we can incorporate in our day-to-day practice. You know, the evidences come like this only. So I bring greetings from my esteemed university as well as the institution, Jain Medical College, Kaher, and the Kayleys Hospital, Belgavi. And I thank the organizers of this CME, and special thanks to Dr. Gitanjali Katgeri, who is the chairperson, which I think Dr. M.J. Ramat, I am correctly chosen a
Yes,
person.
100%.
So that is why I just wanted it. And she was so persistent that I should be there for this program. Thank you, Gitanjali, Dr. Vidya, Tabi, and all others, Bharti. I really thank you for providing me this opportunity. Without wasting much time, I will go ahead with the conceiving the research question. Actually, what is research is actually one should have this research question. By doing the trial or the study, we are answering this research question. So to get the research question is itself a first step in the research. And what is research? See, research is a type of scholarship. Can 1 minute, I'll just hide this. So what is research is? Research is a scholarship. That is scholarship characterized by clear goals, adequate preparation, appropriate methods, significant results, effective communication, and reflective critique. Don't think that what I have done is always correct. So you may have certain deficiencies. And you know how the research question is conceived is that you need to have a workup, study, understand, search the literature, and then when will come to know. So the question of what is research, it is a systemic inquiry, a question and logical approach to answering it. That is research. So by empirical or using data that can be observed, recorded, or measured. By using this, what we are doing? We are doing a systemic inquiry. And to answer a question with biological approaches, having a proper data collection, which can be observed, recorded by measurement. And then that is tested in a generalizable theory. It is indirectly scientific method of acquiring knowledge and establishing the truth is what is research. So what is the purpose of research? The purpose of research is to establish the truth and add to the science. Just want to give you one example here. 1970s, Liggins, the first person to use antenatal corticosteroids, and they developed the dosage. What were the consequences of the dosage, and whether what happens to those babies which are not delivered preterm, even though in 1990s NIH did the study on the use of antenatal corticosteroids, it came up with a suggestion that it reduced the RDS, necrotizing enterocolitis, and all other complications in a preterm babies. But even that study did not look at the babies which did not deliver preterm. They went on to term, and what happened to them was not known till we did the trial in 2011 to 14, and our article that is published in Lancet, Antenatal Corticosteroid Trial or ACT trial, showed that the babies who were delivered preterm, they had benefit, but those babies which went on till term, there was increased sepsis, morbidity, and to mother also there was increased sepsis when the delivery did not occur preterm. So please understand that research is not a stagnant, it is a continuous process. So I'll give you some more examples of how these are evolved. So what are the objectives of the research? Objectives of the research should be benefit to the patients or community, or to help us evidence-based management, to improve the health practices. Today, we are not using antenatal corticosteroid unless the woman is going to deliver within 72 hours. If you use steroids and the pregnancy goes beyond a week, there are increased risks. So that's why we are giving only steroid when the delivery is imminent. So the third practice is we changed our practice and to add to the scientific knowledge. Currently, what we are using the betamethasone is a higher dose. So there is a study which has shown that this higher dose is associated with complications. And there is now we are doing a trial wherein the dose of betamethasone is 2 milligram versus 12 milligrams. So you can understand that how the science and the research evolves and our practices change based on the evidences what we get. So what is research question? Uncertainty about something in the population which the investigator wants to resolve by measurements. See, everyone talks. I'm giving an example. This year I have given one of the topic to my resident is that the late cesarean sections in labor, cesarean section late in labor, a cross-sectional study. We all know that there are complications in late cesarean sections in labor, but how are we measuring that? So we want to look at in this population what is happening. Late in labor we have defined is beyond 6 centimeters of cervical dilatation. So you all know that late cesarean sections, there are increased morbidity, mortality to baby, mother. So we want to find out whether really is it associated with this. And as a subsequent person can take up that what happened to those cesarean sections which were done late versus early cesarean with relevance to occurrence of the subsequent pregnancy complications. So that one person, and because in Western world, there are a lot of data which they are recorded. That's why they retrospectively are able to find out what happened to this. Unfortunately, in India, still majority of the data is not computerized. I think somebody is open. Please mute yourself. So it's
Sir, you're muted, sir.
You're
You're
muted.
muted.
Can you hear me now?
Yes, sir.
Yeah. See, what is the research question is you are answering by this method. That is the objective of the study. So what is the research topic? So research question, what topic or idea of the study you are interested in? What has already been done in this area? That is, we need to look at this literature. What are the major outcomes? That is, dependent variables you are interested in. So these are the research questions we should put ourselves when we are able to do, when we are planning a study. What interventions we are going to do it? We did a simple trial I want to share with you. That is consanguinity. In South India, there is almost 26% consanguinity. Does it have any impact? So consanguinity was the intervention is like, it was a cohort study, exposed versus unexposed. So we were looking at birth weight, consanguineous couple, what was the birth outcome? Then are you looking for differences in relationship?
Is not there.
So differences, for example, consanguineous couple, what is happening? Non-consanguineous couple, what is a birth weight? So we did the study and published in Perinatology Journal, showed that consanguinity is associated with low birth weight. The explanation is the antigenicity difference between the partners is more, the birth weight of the baby is more. So in consanguinity, there is antigenic similarity is more. That's why birth weight is less. So we proved this and published this. And to what group, the population, do you wish to apply these results? We are doing this now. We proved in the hospital-based study that IV iron, when we give for a pregnancy anemia, to iron deficiency anemia, as well as for iron deficiency individuals, it benefited. If the same is to be used in the community, we need to first use in the community. So we are currently doing this rapid iron study where it is done in the community, and we need to see what are the complications we face. Is it easy, feasible? Is it acceptable? All this we need to look into. So that's why you want to do for which group or the population. If it is done in Australia, America, we cannot directly bring them. Their population is different. Our population is different. Their way of looking at the research is different. Our people looking at the research is different. What answer do you expect to find to your question? And that is, you are testing the research hypothesis. And why is this question important today? You must have seen COVID was not there before. So there were COVID related studies came up because it had its own impact. So what instrument? I just want to tell here for postgraduates, they think that data collection is another case record. It's not case paper. Please understand. Your data collection instrument must be appropriate to your study. Your data should be used to actually analyze this. So that cannot be like, I am sharing one of the data collection form later. There, your instrument should be Excel, that is Microsoft Excel acceptable, so that the analysis becomes easy. And what are the qualities or scores which we are looking at that. So research design, do you want to intervene or simply observe? Do you need a control group? How will you control for confounding variables? For example, I am giving you in consanguinity when we were doing, there are other variants for low birth weight. That is socioeconomic status, BMI, and as well as the nutritional aspects. So, and API and APL and BPL, above the poverty line and below the poverty line. All these had the impact. So when we proved the study that we have different methods to find out whether it is independently having impact. That is, it is having impact along with others. And when there are multiple factors are affecting this, you have the measures by statistics. We can find out whether they are independently associated with this. What is the best research design to answer your question? So we should think about it and then aptly answer. I want to give an example here is, see, cesarean section versus vaginal delivery. We cannot have, long-term trial. Cesarean section versus vaginal delivery, we can do. But your objective is when the study should end. Is it the outcome should be at 6 weeks? Because if you say lifetime, there are the perineal deficiency or pelvic deficiencies, all these can happen. So please understand that we should design a study which is appropriate, which should be feasible, and it should be the cost effective. So what is the best research design to answer your question? Statistics and sample. Which statistical method is optimal? What are your criteria for inclusion and exclusion of the participants? How are you going to obtain your participants? If an experiment, how will you assign the subjects or participants? Experimental means I am talking here interventional trial. So how you are going to assign the participant and how many participants you need? And data collection and quality. How are you going to collect the data? Who is going to collect the data? Where are you going to collect the data? And who is going to monitor the quality? I want to give you one example in one of the study where we did in hospital, which proved that intervention reduced the preterm labor by 66%. Same we went in the community where that gadget of gestational age assessment was subjective. We could not establish the same intervention establishing in the community. So what I want to say here is gestational age establishment, if we are using in the community, we decided from the study that we should have an first trimester ultrasound, and that will give the gestational age proper, because if you are doing gestational related, age related study, preterm labor it was. So timetable and budget. What is timetable? When are you going to prepare your protocol? When are you getting the ethics approval? When you want to apply for CTRI? Please remember, if you want to publish your study, it must be Clinical Trial Registry of India must be registered. If you are doing international, it must be registered with International GOV. Even if the trial is registered with CTRI, it is fine. Who will be doing what? That means which person is assigned for what work? What equipment or materials will be required? How much will it cost? When we ask our PGs to submit the budget for your study synopsis, they only put, the for the materials, the papers, printing and all, and also about the dissertation cost. They do not understand that the institute spends for the investigation. The institute also has to have this MS Excel sheet, and you are supposed to pay for the statistician. And if you are developing the DMS, data monitoring system, wherein your all data what you have collected must be entered into, which will help in analysis. They all must be included. Apart from this, the personnel involved, their salaries, all these are to be considered. What is protocol? Protocol means the study you have planned, but what you are doing in the study is protocol. Basic, very simple is you must write a protocol, see that this is my research question, this is how I am going to do, and this is the things which are required. So that is protocol. How are you going to implement this protocol is called as manual of operation or MOO. So please understand, when you prepare a protocol, indirectly it is in brief. For PGs, we call it as a synopsis, but there are to be proper methodology where it is to be done, who has to do it, when it should be done, and what are the exclusion, inclusion criteria. All that must be done. And in MOO, how exactly you are doing this? That is called as manual of operations. And please understand that your study must be ethically approvable, or you should have you have to follow the ethical principles, 3 fundamental principles of ethics: respect for persons, beneficence, justice must be incorporated into your study. And please understand, literature and bibliography must be properly documented and must be searched in Vancouver style, which is acceptable internationally. And all authors must be given their due. 6 authors. And if there are more than 6 authors, after 6 authors, you put at all when you are giving their reference. See how to get a research question here. For an established investigator, very easy. Even there, to get the grants, it is very difficult. But for an established investigator, one can go ahead and do it. For example, the antenatal corticosteroid, we designed after that it showed the sepsis in higher. There actually WHO was in preparation for implementation research for multi-country. But because antenatal corticosteroid proved that there is harm associated in babies who are not going to deliver preterm. So they designed the study. We are currently doing action 1. We did action 1, which showed that antenatal corticosteroids really help in those babies who are delivered preterm. And then subsequently, we are having action 2, different period of gestation we are looking, that is early preterm versus late preterm, and late preterm now dose pattern we are looking at. So any limitation, you must read the article and they write the limitations in that. And if you incorporate that limitation as, this was the limitation in that study, we are taking care of this limitation and we are doing that study. So you can do the same study incorporating this with the questioning that limitation was in that study. We are now taking care of that limitation. For a new person, you need to either be, alert to new ideas and techniques. You must be observing. When you attend the meetings like conferences, scientific meetings, your mind should be open. You should have skeptical attitude and you should be open for new technology. Then one can be able to do that. Today, we are establishing the hemoglobin on telephone. The pulsatility index, which will tell you what is the hemoglobin. Oxygen saturation will tell you what is the hemoglobin. We want to give you an example that we did a study on the blood pressure using the traffic signal. And what we noticed in our population was many of the pregnant women, they showed the yellow signal. And that was, we thought then that is this anemia which is giving a shock index, higher shock index. That is, shock index is heart rate divided by systolic blood pressure. So then we did one study and showed that this yellow signal which was obtained, we confirmed that by hemoglobin estimation that these women were anemic. See, you need to be open for ideas. Then you must have master in literature. So you should be looking for meta-analysis. Whenever your research question is given by your guide, go search on the meta-analysis which are available, reviews, attending meetings, and people who have worked on this, you be in touch with them by mail. Today, all publications, the first authors' names are there on the publication. You can communicate to them by mail. Talking and writing to the investigator and apprentice to experienced researcher. That's what guide is all. Guide and PGs. But you as a PGs must listen to your guides and try to plan out. So this was yesterday's paper, which has been given a review on the expert consensus guidelines on intravenous iron uses, formulations, administration, and management of reactions. This has come just yesterday, and because I am in good touch with Dr. Michael Orbach, who is one of the main authors, he is the last author. He was the primarily involved person. So you can read such things, and then we can incorporate how to reduce reactions, how we should use. So these type of knowledge, and this also, new iron and dosing. Currently the best iron is sucrosomial iron today, and this iron is a lysosomal iron, and which this is one important, and because it is associated with this is sorry because the oral iron, if you give on daily basis, the hepcidin level goes up. So do you really give iron every day? Should not be. So one started using every day versus alternate day. Another person every day versus alternate day versus twice a week regime of oral iron. See, you can get the ideas provided you are open to learning. Keep the imagination roaming by observing, by teaching, by creativity. See, the technique of cesarean has evolved so much. We are going back to 2 layers from 1 layer. So many years we used to do 2-layer closures. We never saw placenta accreta nor cesarean scar pregnancy. Today we are seeing more because there are some different techniques came up in between, and people started suturing single layer in a way they want. Single layer method closure is done properly. There also it should not be a problem, but it can create a problem, and there is still a confusion, and the still studies have not shown that which is better over the other, because we are not doing a long-term trial with this. So one must be persistent. For a research, you need to be tenacious personality. If you are not having tenacious personality, today I am interested in hysteroscopy, tomorrow I'll move to laparoscopy, other day I will go back to obstetrics. That type of approach probably may not help to learning research. So characteristics of a classical research question or the research study should be the mnemonic finer. You use the mnemonic what is known as finer. Finer is, it should be feasible, it should be interesting, it must be novel, ethical, and relevant. And each one I have elaborated. Feasible means it is always best to know the practical limits and problems. Is it adequacy of number? So you may think of a great trial, but do you have sample in your institute? Do you have time that much? Do you have people for it? You have equipment for that. So feasibility is adequate technical skill, affordable in time and money, manageable scope. Too many people are required, and that you should think. It should be interesting to yourself as a researcher, and it should be interested in that field. And secondly, you should consult experts. What is the area in this? Mentors and others, and funding agencies if you are doing a funded research. But you need to have, the study must be interesting. It must be novel. Doing the same, it may not be of much interest to anyone. So you must always read in BMJ publication in 1981, what turns a looker into reader, an article. That type of study results and publications we should have. What turns a looker into a reader, that is the type of study we should publish. It should be new knowledge, new technique we should be having. It must be ethical, high risks, and privacy must not, privacy should be maintained, and not to treat like guinea pigs the participants. It should be relevant. Imagine the outcomes, how important these are for the population, and study in one country must be applied to the same, or the results of this cannot be applied to somewhere else unless that country was involved in the study. So please understand, the anatomy of the research is the elements of research question, design, participants, measurements. First, always write the concept of 1 or 2 pages, then elaborate the protocol and write how are you going to do, that is manual of operation. So in conclusion, research can no more be divorced from the medical education than can a medical education be divorced from the research. So in 1990, when I joined as a teacher in the medical college, and today what we practice, there are lot differences are there. And please understand, these all evidences have come over the technology and which evolved over a period. And we are thankful that we have been adapting to changes. So with that, I conclude, and please understand your research question must be final, feasible, interesting, novel, ethical, and relevant. The finer word, please remember all postgraduates, and thank you very much if there are questions. And how to prepare DCI? This one word I want to tell, because Dr. Hiremat sir, when they are asked to prepare a pro forma, they will write another case paper only. It is not case paper. We should have this, what is your age? This should be in years. And how the woman is between. So we should have this, LMP. If it is certain, the date must be like this, because computer must be able to access to it. And when you want to analyze, it should not be, written. They write, per abdominal examination. One of my candidate wrote, is it a case record or is it a data collection instrument? It should be fundal height in weeks and the measurement in centimeters. They all must be objective, and that is how the presentation or the data collection instrument must be. So with that, I thank the organizers for providing me an opportunity. It is a too elaborate topic, but I have tried to simplify. If there are any questions from anyone, I'll be more than happy to answer. Thank you.
Thank you very much, Bellet sir. You made choosing the research question, which itself will be a very big question for our postgraduate and for us also when we begin a research, how we actually gel the our field of interest with the outcomes we want or the results needed, and then finally put it into a protocol to create a manual of operation. Thank you very much, sir. If any questions are there from the audience, we would be happy. Just 2 or 3 questions to
I'd just
receive.
like to comment actually, Dr. Shruti, about Dr.
Yes, ma'am.
Bellad and
Yes,
the way
ma'am.
he has practically oriented us, because I have been to Belgavi just few days back as an examiner, and I've been to the center of research which Dr. Bellad has created. For last 20-25 years, he has been working, and everything and he has said and told in this topic, already he has done it, and practically he has shared his experience through the various projects he has conducted. The recent one is the Rapid Iron one, which we are doing, the steroids, the Champions trials. These are all come from Belgavi under the leadership of Dr. Bellad. Thank you, sir, for being with us. And thank you very, very much for leading us.
Thank
Yes.
you, Bella, for the nice presentation.
And
Thank
it was
you.
so simplified, I must say.
Practical
For the
questions.
pose. Yeah. It
Yes.
was simplified.
Yeah, but
I
it is a
welcome
teamwork.
Dr.
Please
Jaideep.
understand. 1 second. It is
Yes.
not my own job. It is a team, and research is a teamwork. Please understand. You cannot do alone a study individually.
Agreed.
So teamwork. Team, I always tell in the motivation is together everyone achieves more. TEAM.
TM.
Thank you, sir. And I would like to welcome Dr. Jaideep Tank, who is the
Yes,
chief
join
head
now.
for today's function,
Yes, ma'am.
Foxy president. And I'd like to welcome, and I would just like to add in his introduction that Jaideep sir's theme for this year is coordinate, communicate, and community. Sir, we are your followers. We take inspiration from you. And first and foremost thing which we have done is coordinate. With KASOGA, we have collaborated as a research team, as a research committee. So both the research committees, the clinical research committees of Foxy and clinical research committee of KASOGA has coordinated, and we have collaborated to have this wonderful workshop on introduction to research methodology. And now you have already been there to listen to Dr. Bellad, how much experience he has shared and how good this will be for our audience. Most of them are postgraduates or early, clinical, early career individuals who will take such a lot of inspiration from this very beautiful topics. So these are galaxy of stars here. And I would just like to say a few words about our Foxy president. Yes, we all know he's a visionary. We all know how planned and systematic he is. But we all know the depth of, knowledge. Apart from that, how much the projects he has led in Foxy. So he has been in Foxy throughout his lifetime. I think 12-15 years or more of his youth he has spent with Foxy, brought in so many projects, USAID, with Bill Melinda Gates. These are all implementation research he has led, and also research in the community, need-based, that which help not only the community, the women's health, but I think even the providers. So both ways he has led us all and inspired us all, and definitely he has been to various organizations apart from Foxy. We have seen him active in AOFOX, CEFOC, FIGO, and sir, we are inspired by you, and we would like you to guide this conglomeration, this event also. So over to Foxy President, Dr. Jaideep Tang. Thank you, sir, for being here.
Thank you. Thank you very much, Surekha, for that very kind, very warm, and very, very, very generous introduction. It is, of course, a pleasure and a privilege to be here. KASOGA is one of our most dynamic and most active state associations. And of course, I'm not surprised when the chief patron is Dr. N.G. Hiremat, sir. Sir, it's always a pleasure to see you and learn from you. Thank you very much for all your advice and guidance over the years. And of course, patron Dr. Nagaraj, president, my dear friend Dr. Vidya Thobi, President-elect Dr. Bharti, Honorary Secretary Dr. Rajeshri, Treasurer Dr. Suman, and special guest and subject expert Charmila. And I must acknowledge all the other Foxy office bearers, Dr. Madhuri Patel, and all the admin team and all the other vice presidents, and the advisors of the Clinical Research Committee, Dr. Bellard, Dr. Shivmurthy, Dr. Madhva Prasad, and Dr. Sudha. And of course, the chairpersons of the clinical research committees of Foxy, Surekha, and of KASOGA, Dr. Gitanjali, and the convener, Dr. Shruti Bhavi Patil. Surekha and Dr. Gitanjali, I think you put together an extremely very important and very, very appropriate kind of a webinar. Choosing a research question, then performing a literature search, then choosing a design, putting together a crisp title and objectives, sample size, and the basics of data analysis, in fact, is the way you would write a paper. And that's why the way you have chosen the topics is extremely good. It's extremely important. I just heard the half of Dr. Bellard's talk. It's always such a pleasure to listen to him. He's so clear thinking, and he's got such great ideas, and you always learn when you meet him. And of course, Dr. Madhva Prasad, Dr. Naina, Dr. Manjula, and Dr. Manish are the other speakers. I think webinars like this are crucial, actually. We often say that India is a data-rich country, but a publication-poor country. And I think that needs to change very dramatically with the richness of the clinical data that we have. The number of articles coming out of our country, the number of peer-reviewed articles, and the number of articles, and even our own journal, the Jogi, should be having actually a much higher impact factor than it does now. And I hope that webinars like this, thoughts like these, and leaders like all of you who are present here will make this happen in the very near future. Thank you again, Surekha and Dr. Gitanjali and KASOGA, Dr. Vidya Thobi, for having me here. It's always a pleasure and a privilege. And thank you again to Dr. Hiremat, sir, for all that he does for KASOGA, for Foxy, and for Women's Health. Thank you.
Thank you, Jaideep.
Thank you very much. Thank you, sir.
Thank you so much, sir.
And thank you for being with us in spite of your busy schedule, and in spite of having so many programs. He has been encouraging all the chairperson to do with a free hand. We have been collaborating, we have been working under his guidance and leadership. Thank you so very much, sir, for being with us.
Thank you, sir.
Thank you, Jaideep, sir, for your kind words. Now we move on. I think Bellad sir has another call, so he will be leaving. So
Dr. Charmila also had joined. Is she here?
has Madam joined, ma'am?
She
can
joined,
also
but
ask.
probably she has left.
Yeah, she's
anyway,
just going to
ahead.
be back. Yeah, she's just going to be back.
We'll welcome her once she joins. Yeah, we'll move on with the next talk, that is performing a literature search by Dr. Madhav Prasad, sir.
Hi.
Sir is, hello sir. Sir is an associate professor, Department of OBG, St. John's Medical College, and he was previously at KEM Hospital, Mumbai. He is a national corresponding editor, Jogi, Journal of India. We welcome you, sir.
Can you hear me?
Yes, sir, you're audible.
Yes, sir. Yes, sir. We can see the screen, sir.
So, thank you for the kind introduction. So, we already had an excellent introduction to the, we got a great overview of the idea of research. So now we will dive into the specifics. So I bring greetings from St. John's, Bangalore, and I thank Kasoga for giving me an opportunity to present my thoughts. So, all the postgraduate students and junior consultants who are listening to this, take a minute, pause, think about one topic that you are interested in doing research in. Now, this next 15 minutes, which we are going to go through while performing a literature search, think of implementing this method into your own topic which you are interested in. So that's the way forward, because you are going to come across so many different topics you are going to encounter. And this method of performing literature search should work well in the topics that you are choosing. So moving forward, the objectives of this presentation are to understand that performing an effective literature search is the backbone of evidence-based medicine. Understand that performing an effective literature search is an important skill component of any doctor. Literature search is not only for the academics. There are a lot of people who may be going into private practice and not necessarily medical college based, but learn how to use PubMed. Understanding that storing search literature is as important itself, and referencing is a skill that can be mastered. So, recently we had COVID and there were a lot of these forwards which were going on. There was this particular forward which really tells you the importance of literature search. The reason the world is so confused about COVID treatment and allopathy is because this is the first time they are brushing so close to how modern medicine works. It works by constant changing, updating, and adapting. We change the drugs and protocols with the slightest change in data. We don't stick to redundant methods. We make mistakes. We identify them, toss them into the bin. We aren't easily proud of our breakthroughs. We constantly criticize them till what remains is the absolute best. So this sort of summarizes what the need for performing a literature search is. That is, what was holding good a couple of years back may not hold good now. So that's the way forward. So let's not get confused. Definitely, all students have to read textbooks, but the textbook is actually based on what was there in journals before. So you have to get a right combination of textbook reading and literature search. Ultimately, your aim is to provide better patient care. So in this context, we have moved into the era of evidence-based medicine. So what is this? So previously, there was trust in the experts. That surgeon is amazing. This physician is great. But no, now we have moved into the EBM movement, which is trust in the numbers. And the triad of EBM says there is a conglomeration, the meeting point between patients' preferences and values, clinical expertise, and best available evidence. When all the three intermingle, that is when we are practicing evidence-based medicine properly. So, good clinical expertise. You're going to a good hospital, you're working, you're learning, you're training yourself, operating, etc. Patient preferences and values. What the patient is desirous of. You're taking consent, you're ensuring patient comfort, etc. But today, we are here to talk about best available evidence from the research. So, we are utilizing a constantly evolving data and information, which is the thing which was missing in the previous years, right? So let's go about performing a literature search. So first, forming a meaningful research question. Sir, in the previous talk had beautifully summarized how to make a meaningful research question. How do you build on it? You build a search strategy, use appropriate tools, you execute the search, and then save the optimized results, right? So suppose we were in 1986, that's the year I was born. What would be the search strategy? I'm sure many of the seniors here would have done this. What would they do? They would go to the library. They would ask the librarian, show us the journal section, open the journal's contents, identify the relevant, mark out what it is, Xerox it, bring it back, and then write. Are we doing that now? No, we are not. We are in 2024. It's fast-paced. We are not going to the library, right? So our best hangout is PubMed. So this is going to be a talk based mainly on how you are going to utilize this PubMed platform for your literature search, right? There are many other resources that are available, but personally and sort of world endorsed, PubMed is the main authority which is giving you an authentic database of information. So what is this? It's the correct name is Index Medicus. It's been there from 1879. Slowly they overlapped from direct print mode to online mode. But the most important thing is the journals and books get added or deleted based on the upkeep and quality of the journals. So if it is definitely there on PubMed, you know that there is a good quality to it and you can trust it sort of. So, however, we now live in the era of information explosion. You know, henceforth, there are going to be a series of screenshots which are taken from the system. So if you see this, I just type obstetrics and gynecology. Look at the number of results that are coming in. The results that are coming in are 5,371. You know, you can see this 5,371. Now, in this, I have not even included pregnancy, women's health, puerperium, etc. So there is a need to be efficient and using a good grouping system. Can we use Google? Okay, you can use Google, but it is mainly a popularity based. Google works on number of hits rather than scientific citation. So if somebody by mistake is promoting, you know, their article or something like that, and that shows up rather than the scientific credibility about it. So let's be very clear. For a medical search, let's not use Google, let's use PubMed. That's the most important take-home message of the talk. So moving on, there is a need to summarize a research question, right? So I think in the future talks, you will come across this. There's something called PICOT model. There is a population, there is an intervention, there is a comparable intervention, there are outcomes of interest, and there is a time period. So whatever the research question is, we are trying to put it into this particular model called the PICOT model. So now, in this particular talk, we are going to attempt to execute the search for an example research question. So I have made a very common research question which we can, we encounter daily. So the question is, what is the role of prophylactic tranexamic acid in prevention of PPH among women undergoing normal vaginal delivery? So you can see here, there is a population, women undergoing normal vaginal delivery. Intervention, prophylactic tranexamic acid. Comparable intervention, no intervention, other oxytocic agents. It's not specified, but let's keep it that way. Outcome, better. That is, there can be multiple outcomes. It could be mortality, it could be need for blood transfusion, it could be duration of hospitalization, need for iron sucrose, anything for that matter. And in this particular research question, the time period is not defined. So with this particular research question, how do I execute a search on PubMed? Let's see. So for those who have who have two systems, maybe you could just open your PubMed and just look it up. This is the same thing. This is how it is going to look. This is how it's going to look, and there is a bar where you can type. And when you scroll down, there are many more utilities. I encourage you all to explore it. So in that particular taskbar, you can use the disease name, condition name, procedure name, technical term as the search term. So I took this entire research question and typed it here. Can you see? It says no results were found. It says no results were found. Okay, so something is wrong. I cannot type the entire research question there. So now I'm omitting medically non-relevant terms. And so you can see what is the role of among undergoing. All these are not medically relevant terms. So I'm just removing the ones in red and pasting this here. Look at this. Prophylactic tranexamic acid, prevention, PPH, women, normal delivery, still no results. So maybe I'm not so good. So many words should not probably used. So I'm excluding further. I'm removing prevention. I'm removing women. I'm removing normal. So I'm putting it here. Now see, the words which are put in here are prophylactic, tranexamic acid, PPH, vaginal delivery. I can see here 15 results have come in. Right? 15 results have come in. So I seem to be on the correct way. Now let's play around with the words a little further. I'm removing prophylactic from here and putting only these things: tranexamic acid, PPH, vaginal delivery. I can see 43 results which are coming. So this also seems fine. However, my original research question had prevention as a term. So it's not there. So let's see how further we can go about it. I have removed vaginal also next. So only tranexamic acid, PPH delivery. Now I'm getting 78 results. So, but here it says only delivery. Vaginal delivery is not there. So these results, this set of 78 results may include patients who are undergoing cesarean section. So moving forward, I'm just checking tranexamic acid, PPH, 120 results. But then now I'm in doubt. Tranexamic acid, PPH, only 120 publications. Maybe my terminology is wrong. Maybe my usage of the term PPH is wrong. So I replaced PPH with obstetric hemorrhage. Now see, tranexamic acid, obstetric hemorrhage. I'm seeing 412 results. So you can see that already something is showing up very quite well. Tranexamic acid and obstetric hemorrhage, give empirically or selectively, like that. So there are now 412 results. Now handling this may be a little difficult. However, we are clear that the term PPH was not apt. The term obstetric hemorrhage was. So the point I'm trying to tell you here is, while doing a literature search, you have to attempt to use a few synonyms, similar words. So, by simply changing a small word without changing the meaning much, you may get much better results. That's the take-home message. Now I'm adding prevention. Now you can see tranexamic acid, obstetric hemorrhage prevention. I'm coming to 192 results, which is much better than tranexamic acid, PPH prevention, right? So moving forward, I'm adding the term vaginal. So now I'm getting 47 results, which is perfect. So you can see here, of course, the screenshot shows only the first result, but it showed me a brilliant result. Tranexamic acid for the prevention of blood loss after vaginal delivery. Is this what exactly we wanted to answer in the first place? Yes. So there may be 46 other results which are similar, but we are happy. We are now good. So with this 47, we can sort of shortlist further, open individually, and look into the various results. So to summarize, when I use too many words, I'm getting too less results. When I use more words, I'm getting little lesser, but when I'm using lesser words, I'm getting too many results, 192. It's a little difficult to handle. So for this particular question, so you remember the research question, there were so many, it was a big sentence, but the best fit of the words are here, and you're getting 47, which is probably the best, right? So we need to just acknowledge that the PubMed search works under Boolean algebra. That is, and is the standard operator. And means it looks for the three words. The three words can be in any particular order. As long as those three words are there, you will get the same kind of results, right? So till now we searched with using a disease condition. Now let's search with author. No, not making a political statement, but yeah, see, I just say Modi 4281. There are a lot of other Modis also. I put Narendra Modi, there are 8 results. Just to emphasize that when you put a particular term, that person can be an author, or that name can be there in the text of the content itself, right? Now I put myself, today morning, and I saw that there are 11 results, and as a mark of respect to the previous speaker, I just searched, Bellad M shows 50 results. So we know the greatness of the person who just spoke, to get 50 results on PubMed is like a great achievement. So you can see that one way of going around doing research is author based also. There is an author who's doing excellent work in the topic. You can just go, search out that author and look at the entire profile, and you can take things forward. This is another method of searching. So 2 methods of searching: one topic based, another author based, right? So to summarize,
ಬೇರೆ ಯಾರು ಬಂದಾರ? ಬೇರೆ ಯಾರು ಬಂದಿಲ್ಲ? ನೀವಿಬ್ರೇನಾ ಬಂದಿರೋದು?
There's some disturbance. To summarize,
Arun,
moderators, can you please?
Arun, mute everyone, Arun.
Sorry, who is
Arun,
this?
please mute.
Please mute.
Mute
Please
everybody.
Arun,
Muted, sir.
but why
Yeah,
so
okay.
much noise?
Okay. So to summarize, for effective literature search, use appropriate keywords or author names, use synonyms, order of words doesn't matter, avoid redundant words like if, but, or, not, hence, etc. Usage of too few keywords give rise to too many articles. Usage of too many keywords give rise to no results found. So you have to create that sort of balance, right? Now, who doesn't use Zomato, Swiggy now? Obviously, all of us do. So you can see, you know, these are all the things: delivery, dining out, filters, rating, safe, hygienic, pure. That's exactly what we're going to do here too, right? So if you look at the PubMed platform, after you have typed the topic or the author, etc., you have all these options too. Results by year. By moving the cursor to the desired field, it can be 1 year, 5 years, 10 years. You can just scroll down. Type of text availability: abstract, free full text availability. No, all these are clickable. Similarly, type of article, whether you want a summarized book and document, you want a clinical trial, you want a meta-analysis, you want a systematic review, anything. And there are some other additional filters also. So now let me just demonstrate. So for this particular topic, tranexamic acid obstetric hemorrhage prevention, I had 192 results. Now, when I click on free full text, it has gotten abridged to 64 results. So, by applying one filter, you're getting lesser number of results, a little more focused kind of results. Now, suppose I want only RCTs. I don't want anything else. I want only individual RCTs. I get 43 RCTs. Since there are a lot of secondary articles like systematic reviews nowadays, maybe we are searching only for RCTs. We are getting a much lesser number. Now, I want only meta-analysis. Maybe I'm writing a textbook chapter. I want only meta-analysis. So I get 32 results. I want articles, only recent articles, 5 years. So postgraduate students and junior faculty who are listening. So, always people expect that we write or quote only recent articles. So 5 years, it's a very good filter to apply. You will get only recent articles. So you can see that out of 192 results, 104 are recent. So it's a topic which is worth doing. So very, very narrow. When I put too many filters, I put free full text, I put last 5 years, I put systematic review meta-analysis. Still there are 4 results, which means there are a lot of active work which are going on in this particular topic. So I just showed you that after entering keywords, you mix and match based on text availability, article type, publication date, and all those filters available. You'll get a good match of. So it's basically about, you have a platform. How are you going to extract the best out of this particular platform is by playing around with the words and using the filters, right? So now, say for example, I have found this article, tranexamic acid for the prevention of blood loss after vaginal delivery. So, in your interactions, you may want to communicate this particular topic or this particular article to somebody. In that, you can see there is a unique PM ID. You can see here 30134136. I hope it's visible. So there is an 8-digit number which is unique. So with simply that PM ID, you will be able to communicate to other people about this particular article, etc. Right? So once I have identified that particular article, if you just scroll down, you will see the section called similar articles, right? So you can see here, there are a lot of other articles which are quite similar, which may not have shown up with your particular words, but they are quite similar. They may be older, they may be newer, but they are similar articles. So effectively, if you find one article which is perfect and you scroll down and look for similar articles, that's also going to solve your problem. Similarly, cited by, we already told you that the power of an impact factor is when something gets cited. So those are also good methods to use these articles, right? So then there is also something called medical subject headings, MESH. So here what happens is, postpartum hemorrhage is also already a medical subject heading. So here you can see it has classified the PubMed platform. When you click on MESH, medical subject heading, it all already gives you a lot of other topics which are sorry, it gives you a lot of topics which are related to the primary heading that you have applied. So you can add to search builder and you can do the needful, right? And moving forward, if we can identify a particular article and you can, access it through your institution, subscribe to a title, or sometimes purchase it. Many a times people are bogged down by the fact that, you'll have to purchase articles, etc. But please go to your library. This is a screenshot from my old institution, KM, where the librarian had written to us telling, we are utilizing it very, very less. So satisfactory search is in progress. How to save it? Since we are running short of time, I'll just make a cursory mention that there are different methods to save references. There is something called Mendeley. There is something called Zotero. There are something called EndNote, BibTeX. A lot of things are there, but my choice is Mendeley. So it's just like an app which stores all the literature material in one particular place. This presentation does contain a detailed entity of how to use Mendeley, but I think we'll skip that for time being. I'll just run through it. There's a Mendeley web importer. It's like any other web tool. You can add it to your Chrome extension and you can use it, and your article comes into your particular app on the tablet, and it is once you sync, it is available for offline reading always. There are YouTube videos on this. I think you can go through this also in detail, right? So coming to the last part of the talk, is PubMed the only source? No, there are other things like Dynamed, UpToDate, TRIP database, CPG guidelines, grade working groups consensus, etc. So there are many other options also, but PubMed is a good starting point, right? So however, we need to be cautious. Problems with easily available information as, we stop critical thinking. We don't know if we are answering the questions we actually want to answer. And sort of when there is too much technology involved, it becomes a form of passive learning and we may become dependent on it. So these are all things we need to be a little cautious about. So to conclude, medicine is an ever-changing science. What is valid today may not be so tomorrow. Correct mix of textbook reading and use of technology is necessary. Efficient use of technology, leverage the technology well. Correct mix of internet dependence and offline storage. Develop your own style. And for me, and so should be for you, literature search is PubMed. I thank all the Foxy members and the esteemed office bearers for encouraging scientific activities. I thank all the Kasoga members for giving a platform to share knowledge. Special mention to Geetanjali Madam, my mentors. Thank you.
Thank you very much, sir. That was a very useful and wonderful information about how to. I'm sure many of us were still using only Google. Now we know that PubMed is the tool where we can use and play around with the words and use those filters and really get the desired results. Thank you very much. I would like to ask if anybody has few questions to sir.
No, thank you, Madhav. Excellent presentation.
Thank you,
have made complete use. You are master, I can tell you. In searching, you are master. I think you need to visit all the medical colleges and go to the Department of OBC, address all the postgraduates, and Kasoga will sponsor your trip.
Thank you, sir.
Okay, Madhav.
Sir, coming from you, it is a great honor, sir. Thank you.
Thank you. Thank you.
Any more questions to sir?
No, he has done excellent job.
Okay,
No
sir.
questions
Okay.
at all.
Thank you, sir. Ma'am, if Chamila ma'am has joined?
No, I think she's not yet joined.
Okay. Then we move ahead with our next talk, that is choosing an appropriate study design by Dr. Swarupa Chakuli ma'am. She is Professor of Community Medicine, JN Medical College, Wardha. She is consultant dermatologist and hello.
Yeah, continue.
Yes.
Hello.
Consultant dermatologist and faculty of School of Epidemiology and Public Health. And she has many publications, international and national, to her credit. We welcome you, ma'am.
Thank you very much. Is the slides visible?
Yes,
Yeah.
ma'am. We can see your slides.
Yeah, thank you. Okay, so shall we start?
Sure,
Yes,
ma'am.
ma'am, please.
Sure. Thank you. First of all, I'll thank the organizers and especially Surekha ma'am, so that I am able to interact with all the gynecologists. We will be talking about the study design options and how to choose an appropriate study design. So before going to various study designs, we know what are the various study designs. We have done various studies also. Many of you might have published the articles also. Some might be PG students who are in the process of doing their thesis and now on the verge how to choose study design. We have to write in synopsis also what is our study design, but that is not the only thing. For that, we should know what are the various study design options. Actually, study design means the actual process of conducting the study. So a study design is a specific plan or protocol for conducting the study. Grossly, the study designs are quantitative and qualitative. So quantitative research is used to quantify the problem by way of generating the numerical data, which can be transformed into usable statistics. It can generalize the results from sample to population. Qualitative research is exploratory research, and it is used to gain an understanding of underlying reasons, options, and provides insight into the problem. Basically, when we are doing a study for postgraduate level or basically for thesis of PG, so qualitative research are a little bit difficult to do. Mainly, we are focusing on the quantitative research. So, in details, we'll be dealing with the quantitative studies today. So, grossly, we divide the studies in two main types: observational studies and experimental studies. So here I'll tell you about the work of two scientists. One is John Snow. You might be have heard about John Snow. He's father of epidemiology, and there was a pandemic, or rather an epidemic of outbreak of cholera was there in London. So John Snow has worked on that epidemic, and he find out what is the cause of that cholera cases, and he found that there was a particular area of London where a contaminated source of water was there, and because of that, the cholera cases were there. So this is nothing but the basic study and the basic observational study, and here we describe the disease only in terms of who is suffering and where are the cases, who, where, and when. So that is the question which is answered. So it was just an observational study, and there John Snow was the pioneer of doing the various study designs. Here is one example of observational study, that is by John Snow. Another example is by James Lind. James Lind was a scientist, and he conducted a study on prisoners, and he divided the scurvy patients in two groups. He divided the prisoners in basically scurvy prisoners in two groups, and he provided citrus rich fruits to the one group, and the another group was devoid of vitamin C, and he found a drastic improvement in scurvy cases. So this is why I have told the example of these two scientists, because one has conducted an observational study, that is John Snow, and another James Lill has conducted experimental studies. So whenever we are giving any intervention, it is an experimental studies, and when there is no intervention, so that is observational study. Descriptive type of observational studies. Our main aim of descriptive study is to generate the hypothesis. We don't see further what is the cause, what is the etiology in case of descriptive study. But when we want to see what is the cause, and the question, our research question is why, at that time we are doing the analytical studies, and there are multiple groups rather than multiple, 2 groups mainly are there in the analytical studies. Now, how to decide what is my study? So first question you should ask to yourself, are you assigning any intervention or exposure? If your answer is yes, that means your study is experimental study. If the answer is no, then your study is observational studies. Again, if for observational, suppose you are generating the hypothesis, you are just describing the disease in terms of time, place, and person, that is a descriptive study. And if you want to test the hypothesis, then it's an analytical studies. Again, the analytical studies, depending on the direction of your conduction of the study, we divide it into 3: cross-sectional, cohort, and case control. According to the direction of the study, we'll come to that. So basically, this cross-sectional study is snapshot study. Case control is retrospective, means already the patients are there with us, cases has occurred, and we go retrospectively to find out what is the cause. In cohort study, we go in forward direction. Means initially we don't have patients with us, only healthy individuals are there. We divide them into groups, and then we see for the effect. So this is just a direction. We will be discussing about, in short, about the various study designs. So let's begin with the descriptive study. So as I have told, the question here we answer is who, where, and when. So descriptive study is the first phase of epidemiological investigation. Whenever there is any outbreak, we are doing this study. At the time of COVID, when initially COVID cases were there and we were not knowing much of the where the diseases, where the cases are occurring, and various things were not known. So at that time, whatever the studies were conducted, those were descriptive study. Of course, at the time of COVID vaccination, when we were focusing on the clinical trials, so this is that COVID vaccine trials, these are nothing but the experimental studies. But when initial cases were studied, that is nothing but the descriptive study. So in descriptive study, we observe the distribution of disease or health related events in human population and identify the characteristic with which the disease is associated. So we discuss about the time, place, and person in the descriptive study. So case report, case series, these are nothing but the descriptive studies. Suppose we get a rare disease of some illness, and suppose we find a rare case of dermatomyositis, for example, and we want to write about that study and we want to publish. So that is nothing but a case report. So detailed presentation of a single case is a case report, and it's nothing but a descriptive study. Many times, previous undescribed disease, if there, or unexplained link between the diseases, or unexplained new therapeutic effect is there, some adverse effects are there. So that is case report. Similarly, if experiences of a group of patients with a similar diagnosis is there, and cases may be identified from a single or multiple sources and generally report on new or unique condition, these are the case series. So what are the advantages of descriptive studies? It is useful for hypothesis generation, informative for very rare diseases with few established risk factors. The disadvantages are cannot study rare and cause and effect relationship also. Cannot assess disease frequency also. So case report and case series, these are the 2 types of descriptive studies. Now coming to the analytical studies. In analytical studies, routinely we are doing sectional case control study. Ecological studies are difficult to do, And so we will discuss these three. So cross-sectional study is a snapshot. We also call it as a snapshot study, or just a point at a time time we are conducting the study. Like data collected at a single point of time is called as cross-sectional study. And it's an observational design, and that surveys exposures and disease status at single point of time. That is cross-sectional study. Here, these cross-sectional studies we do or we conduct to find out the problem statement, like what is the prevalence of a disease, what is the prevalence of cases in particular district. You might be remembering that at the COVID time, we used to divide the regions in like green zone, orange zone, red zone. So those zones we used to decide after doing the cross-sectional studies only. Like we used to do ki kitna prevalence hai. So that was a cross-sectional study. Here we can see one example of cross-sectional study. Like suppose study population is there, and we want to see for any disease is there or not, no disease, and we will find out the risk factors for both. Like suppose playing outdoor games and overweight, these things we want to study. So we can take adolescent school children as a group, and in that we will find out how many are obese and how many are non-obese, and we can see in obese how many are playing regular outdoor games. So this is just an example. Now why we have to do cross-sectional study? It is to assess the burden of disease in a population and to assess the need for health services. Only knowing the disease burden will not be enough. We should be able to provide the necessary things also. We have to compare the prevalence of disease in different populations. At that time also, we do the cross-sectional studies. Suppose we have to see for how many cases of we can say breast cancer is there in various districts, and like urban rural we can compare. So at that time we can do the cross-sectional studies. We have to examine the trends and disease prevalence also. At that time also we can do cross-sectional study and to find out the associations. So this is an example of cross-sectional study. Now coming to the next two important studies, that is case control study and cohort study. This we discuss whenever we discuss any topic, we simultaneously discuss these two studies, because apart from the direction of the study, most of the things are same. Like in case control studies, the cases has already occurred, means we are taking the patients and then we go in retrospective direction. In case control study, most important thing is about matching. We take one case, we have to take one control. So 1:1 ratio of cases and control is important. So the name case control study. So cases and control. So patients we are taking, controls we are taking, we are going in retrospective direction to find out what are the risk factors. So here we can see one diseases and multiple risk factors can be studied. So now what is case control study? It starts with people who have disease, match them with controls that do not have the disease, look back and assess the exposures. Here, the case definition is also very important. Like for a clinician, we can just from clinical signs and symptoms, we can label that, okay, this patient is, we can say that suppose tonsillitis, inflammation of tonsils, clinician can say, oh, it's a enlargement of tonsil and inflammation of tonsils. Clinician can say it's tonsillitis. But for a definition of a case control study, it has to be completely defined, like enlarged tonsils with inflammation and diagnosed on lab investigation with confirmed diagnosis. So that is important in definition of cases. So here we will take again the same example of adolescent obese individuals. Here obese and adolescents are our cases and normal adolescent are controls. And then we will go in retrospective direction and study for the whether how many were playing outdoor games in both the groups. But here we can see that only playing outdoor games can be studied, multiple risk factors can be studied, like obesity related for the risk factors for obesity, like family history and sedentary lifestyle and all other risk factors. In case control study, we find out the odds ratio, and in cohort study, we find out the relative risk. So coming to the cohort study, cohort is defined as a group of people who share common characteristics or experience within a defined time period, like age, occupation, exposure. The cohort can be birth cohort or exposure cohort. So just a similar character, birth cohort can be there, marriage cohort can be there, occupational cohort can be there. So we select people having similar characteristics. Here, what is there? We begin with disease-free individuals. In case control studies, individuals we are taking, and in cohort studies, whatever the study group is there, this is disease-free individuals. We classify the patients as exposed and unexposed. We record the outcome in both the groups, and we compare the outcome using relative risk. So this is also called as prospective study or follow-up study or incidence study. Here we can find out the incidence. In cross and for finding out the prevalence, we are doing the cross-section studies. Same study, if we take the same example, so here we have to see for healthy adolescent individuals at the beginning. So our study participants are healthy adolescent individuals, and then we will follow them over a period of time and find out how many of them are becoming obese. So this is a cohort study. But here we can see that multiple outcomes can be studied simultaneously with one risk factors. Here the risk factor we are looking into is playing outdoor games regularly. So in a cohort of adolescents, we will be making two groups, one playing outdoor games, another not playing outdoor games. Both will be followed, and in both the groups, we will find out how many has developed obesity. So this is nothing but a cohort study. So coming to the last study design, that is experimental studies. Here we are doing some intervention. That intervention can be in the form of drug, or it can be in the form of vaccine, or any like any modality of some new test can be this. Now, what are the types of experimental studies? So randomized control trial and non-randomized control trial. Here, the randomization is the difference. Like, what is randomization? Suppose each and every study participant has an equal opportunity to enter into the study. That is achieved by randomization. So there are certain methods of randomization. Like we will say flipping a coin can be one method, taking random table number, just seal envelopes. So these are various methods of randomization. So these experimental studies are also called as intervention studies. And the objective is to know the effect of intervention, and individual is entering into the study criteria. So we have discussed what is randomizations, like participants are allotted in two groups depending on the criteria. Here the same example I have taken obese students. Intervention will be in the form of regular exercise. Controls are there who will not be doing the regular exercise, and we will be finding out how much is the decrease in BMI in both the groups after doing the intervention. So just regular exercise can be also an intervention, not necessarily vaccine or drug is always there. So this is the brief outline about various study designs which we have gone through. So suppose we want to find out the prevalence. So our type of study which we will choose is cross-sectional. Suppose we want to find out the incidence, then cohort study. We want to find out some causal association. We want to see what is the risk factor. So at that time, we have to do case control or cohort study. And suppose we want to see for the treatment efficacy, what is the treatment efficacy of any drug, any vaccine. So at that time, we are doing the randomized control trial. In randomized control trial, one thing is important, that is blinding. So in blinding, we like mask the individuals knowing, like single blind, double blind, and triple blind. These are the three blinding methods. In single blind, we don't tell the patient whether the patient is receiving the drug or placebo. In double blind, patient as well as doctor is not aware. And in triple blind, patient, doctor, as well as the investigator. So this blinding is important thing in randomized. So this is the last thing which I would like to tell you is about the hierarchy of study designs. We can see that basic study designs is case series, case report, these are the basic things. After that, cross sectional. After that comes case control study, then cohort study, and then RCT. So RCT is having the highest weighted, that you all know. In qualitative research, what is there? In qualitative research, it can provide insight into the problem which is not possible with purely quantitative data. A means for exploring and understanding the meaning individuals or groups ascribe to social or human problems. So study human behavior and social things are there in qualitative research. Now coming to the end, so at this moment, we can answer various questions like what is a rare case is there of dermatomyositis, which study you will be doing. So it's a case report. Suppose we want to find out the prevalence of hypertension among adolescents in Bhubaneswar city, for example. So what study will be doing? It will be a cross-section study. To find out the association of bottle feeding with the incidence of diarrhea, so at that time we'll be doing the cohort study. Association of smoking and MI, case control study. Suppose we want to find out the safety and efficacy of malaria vaccine, so at that time we'll be doing the RCT. And suppose we want to see the to explore factors of non-use of contraceptives in a tribal community, at that time we have to do the qualitative study. So this is the summary, nutshell summary of various study designs. So that's all about various study designs. Thank you.
Thank you very much, Swarupa ma'am. It was a very nice presentation about how to choose a study design depending on the subject you have chosen or the topic. If we have any questions for ma'am.
There is one question in the chat box, Shruti. So, ma'am, the question is, if we want to test a grading system of severity of an event on the outcome, what is the study design we should select? Chaitanya, would you like to ask or interact directly?
What is the question?
Ma'am, I'm Dr. Chaitanya, ma'am. I'm
Yes.
pursuing the MCH degree. So
Yes.
I wanted to choose the study design for the topic I want to do thesis. So I wanted to test a novel grading system for one type of procedure and its outcome, like its effect on the reproductive outcome. So I wanted to know what is the type of study design I wanted to choose.
It's an experimental study because you are doing intervention, and it is an experimental study. You can take two groups will be there, and you will be comparing.
Ma'am, I won't be doing any intervention. The already existing procedure is there. I am going to grade the severity of the event. For example, I wanted to grade the severity of a difficulty of the embryo transfer.
Okay.
On the
So it's an
reproductive
observation.
outcome.
It's an observational study. Then it will be a case control study. You'll have
Case control study, ma'am.
Yeah.
Okay, ma'am. Thank you. Thank you.
Swarupa, I beg to little differ for Chaitanya. She is looking for the difficulty level of embryo transfer of different techniques. Am I right, Chaitanya?
So that's why I was telling that it's an RCT. So he might be doing that intervention.
No. Probably she wants to see from the records. Are you looking at from the records?
No, sir. We already have a preformed procedure. I
Okay,
wanted to grade the difficulty of the embryo transfer technique.
correct.
No,
But
but
you
though
know, the
you are
difficulty,
not doing, but though you are not doing the intervention, but it has already been done, someone else has done, and then you want to just grade. But the intervention is there.
are you doing prospectively or retrospectively?
Prospectively, sir.
If you are doing, then there has to be a pro forma and the procedure what is being done and the level of difficulty you have to grade there. And the person who is performing, if it is easy, not so easy, difficult, very difficult. So if he puts these and you need to look at those, and that is how you are going to do it. It's an observational study.
It is an
And from,
observational study.
yeah.
I do
Okay,
agree, sir. It's an observational study.
Okay, sir. Thank you. Sir. Thank you, ma'am.
Thank you very much. I think if we do not have any more questions, we'll move on to the next talk. Hello. Hello.
Priti, I think you can go on.
Yes, ma'am. So our next topic would be putting together a crisp title and smart objectives. For this talk, we have our next speaker who is also very crisp, clear, and a very sharp speaker, Dr. Nayana Ashilkar, ma'am. She's chairperson, Board of Studies Paraclinical Subjects, KAHER, and co-convener, MCI Nodal Center for Faculty Development, JNMC. And she is a resource person in various medical education and research methodology workshops. We welcome you, ma'am.
Thank you, Dr. Shruti. Thank you for that introduction. I'll just share my slides. Are the slides visible?
Yes, madam.
Yes,
Okay.
ma'am.
Thank you. Okay. A very good evening to all of you all. And at the outset, I would like to thank the organizers for giving me an opportunity to be a part of this online CME, especially Dr. Geetanjali. The topic that I have with me is putting together a crisp title and smart objectives. So title, yes, is it important? And yes, it is very important because this is something like the face of the paper or the face of a research proposal, right? And it is one of the it is the one which gives you the initial impressions, like what is going to be in the paper. So this is a very important aspect because whether, we don't know how the impression is going to be, thumbs up or thumbs down. So that is why we need to make the title quite concise, very clear, attractive, and impressive. So what is the importance of just a minute. Okay. What is the importance of the title? Why is it so important for us to write a crisp title? The reason being is yes, it is first and most seen and most read part of any manuscript. For the reviewers, it's also very important because they get an initial impression of the paper. This also applies when, as a PG, we are submitting a synopsis for review. For editors to decide whether to process the paper for further review, as well as for the readers, because maybe most of the time this is the only part of the paper that is available for them to read freely, and hence this is most read part of any manuscript. So a strong title can pull the readers and encourage them to read, but a weak title dulls the reader's expectations, negatively affecting the views on the research. And no matter how good actually the research has been done or how well the research protocol has been written. Hence, it needs to be concise, simple, specific, functional, yet appealing. So this is what is the importance of the title. And therefore we need to put in some efforts and some time to write such a crispy, important title. Okay. Also important is, it is important because it is crucial in ensuring that the access to the readers, especially when they are searching through the electronic databases and search engines and also on the journal websites. So title is the most important part for those reasons, and therefore it has to be one of the priorities while writing the synopsis as well as while writing the research papers. And therefore, having a good and inviting title is a priority that we need to give. Now let's come to the types of the titles that we could have. Now functionally, we could divide them as descriptive, declarative, and based on question, that is what we call as interrogative, or morphologically nominal, compound, or full sentence. Now what is descriptive? Descriptive is also called as a neutral title. Now this type of title has the essential elements, including the subjects, designs, intervention, comparison, control, and everything, but it does not reveal the main results or the conclusions of the paper. It has got several keywords which are again very important, and these type of titles give a glimpse of the paper, and these are the ones which are generally preferred. These are the ones which are most read as well as most cited. While we have the declarative titles, now declarative, as the name suggests, it means that the title itself declares what is the finding or what are the results of the study. So these may reduce the curiosity of the reader because the title itself is telling what is there in the paper. It may also reflect the intrinsic bias regarding the interpretation of the data, and these, as far as possible, these should be avoided. Then we have the interrogative. The interrogative, again, as the name suggests, it has a question or it has a query or the research question in the title itself. It can sensationalize the topic, but most of the times it is more it is downloaded but less cited. And these can also prove to be distracting to the reader, and therefore again best avoided for a research article. However, it could be used for a review article. So if we need to decide, especially for the synopsis, for the beginners, what type of title we need to have for our synopsis or dissertation, it is always the descriptive type of title that we need to write. Okay, now let's come to 7 secrets of writing a title for the research proposal. Okay, so these are the things we need to keep it concise, be very specific, decide regarding the place of the study, use a descriptive or a neutral title as we have already discussed, avoid interrogative or declarative titles, avoid acronyms or abbreviations in the title, and yes, most important part, appropriately spiced. We'll see what the spiced is. So first, coming to keeping it concise. Now, if the title is too long or too complicated, it may just put off the reviewer or the readers right at the onset itself. So keep it concise, use maybe 10 to 12 words that enable you to bring, or up to 15 words, which will enabling you to bring out the essence of the research work. So that is more important, and essence should include the patients or the species, design, intervention, comparison, outcome. So let's look at one of the title, a very big title. I'm not going to read the entire title, but what is required here was NS1 antigen and the diagnostics. So this, when we start reading such titles, it takes ages to read, and also no patience, to go through the entire title. Instead, we could also write NS1 antigen test for the diagnosis of dengue fever. So this looks more concise, and it also permits the reader to proceed on to the next session within his or her attention span. So therefore, the conclusion to be concise is that you avoid unnecessary phrases. Next is keep it very specific. Now let's look at this title, Vitamin D and Pneumonia. Very concise, but doesn't look specific, because this is very concise, but still lacks the power to specify what is actually being done with this study. So it does not lead to any particular direction, and also leaves the informative work to the other parts of the proposal. So even when we say that it should be concise, we just don't mean that it should be concise. That means restricting the number of the words, but it should also be specific, highlighting what is the main objective of the paper. So if we rewrite this title as Vitamin D deficiency and risk for severe pneumonia in under 5 children. So this is concise as well as more specific. So next is the place of the study. Should it be included in the title? Now that depends upon what is our primary objective. So let's look at one more example of the title here. A study on prevalence of hypertension in young adults in Mumbai. Now, is the place of the study important here? Okay. Now, here it all depends, as I said, as on the primary objective. If, like a particular, when we are mentioning a particular place, if the study has got something to do, the objective has got something to do with the geographical location. As for example, here we see Mumbai, okay, a metro place, and we are looking for the prevalence of hypertension. So maybe the conditions which are prevailing in this area, like the prevalent lifestyle habits, economic status, cultural and social practices, could be a reason for hypertension. So in such a title, we could definitely mention the place of the study. Okay. While if we look at another title here, daily versus weekly iron supplementation in adolescent girls in Delhi. Now here is the location, that is Delhi, really required. Now here, if we look at what could be the primary objective of this study, we definitely analyze that the affecting factor is just not the socioeconomic or the political environment, but evolutionary buildup. So in such conditions where geographical area doesn't play any role in the main objective or in as a causative organism, a causative reason for the disease, then we need not mention the place. So it all just depends. Another example here, methylprednisolone versus cyclosporine for treating childhood aplastic anemia in Manchester. So here again in Manchester, be it Manchester or any other part in the world, it is obviously we want to look at what is the utility of methylprednisolone versus cyclosporine for the treatment of childhood aplastic anemia. So in such conditions where the area does not have any place in the main objective, then we need not mention the place. So here in such cases, the places becomes redundant and can be avoided. Yes, one more important thing to be noted while writing the title is place the key words towards the beginning. So this is really very important, and that gives more meaning to the title. Like for example, rituximab for the treatment of autoimmune hemolytic anemia looks better than treatment of autoimmune hemolytic anemia with rituximab. So placing the keywords in the beginning of the title also makes it more attractive and meaningful. If you look at another example with the same intention, like where we want to study, the differences in the prevalence of obesity between men and women, we could think of various titles. Let's look at two titles here. One, prevalence of obesity in adults by gender, or gender differences in the prevalence of obesity in adults. Now, if you look at both of these, we find that what is more important in this study is we want to know the gender differences in the prevalence of obesity, and therefore placing that at the beginning of the title makes it more meaningful, because that is obviously the objective of this study. Okay. Can we use colon in the title? Yes, this is we can, where we are mentioning the study design. Like for example, as we see here, azithromycin for the treatment of enteric fever, a randomized control trial. So just before the study design, we could use this. Okay, we have already discussed this using that whenever we are writing a title, let it be descriptive or a neutral one, where it explains everything that is there in the objective, but does not declare any results. Say for example, 7 days versus 10 days antibiotic therapy for culture-proven neonatal sepsis, a randomized control trial. Having said this, we have already discussed avoid declarative titles, like for the same objective, 7 days antibiotic therapy is better than 10 days antibiotic therapy for culture-proven neonatal sepsis, a randomized control trial. So this title is already declaring the results, which is actually should be avoided. Yes, similarly, avoid query-based or interrogative titles. The same thing. Is 7 days antibiotic therapy better than 10 days antibiotic therapy for treating culture-proven neonatal sepsis? So the moral of the story that we get here is that use declarative or use descriptive titles mainly for these types of research. Yes, avoid abbreviations and acronyms in the title. It's always better to avoid these. Like for example, if we write diagnosis of ARF in children, now ARF could mean acute renal failure, or it could also mean acute rheumatic fever. So, however, if some of these abbreviations which appear as word entries in the Webster's Collegiate Dictionary can be used. Like for example, we have HIV, AIDS, NADPH, ATP, such abbreviations could be used, but as far as possible, avoid using abbreviations or acronyms in the title. Okay, the most important part of the title, which I had mentioned as the last part of parts of the title are the ones which includes the spices. Now this is called as spiced. So what are the spices of a good title? S stands for the setting, P for population, I for intervention, C for condition, E for endpoint, and D for design. So let's look at each of these. Setting. Setting means it is a situation in which the research takes place. Okay. Now, when the results are not generalizable to other settings, or if the settings reflect the magnitude of the research, then it is always better that we mention the setting. So it could be, depending upon, again, the research question, it could be community-based, school-based, hospital-based, or lab-based. It could also be done in outpatient, inpatients, or emergency rooms. It could be rural or urban. Like, for example, if we look at this title here, mortality in severe acute malnutrition in under 5 children, a hospital-based study. Is the situation or the setting important here? Definitely yes, because the mortality in severe acute malnutrition will be different in under 5 children admitted to the hospital and those who are there in the community. So in such situations, it's always better that we mention the settings. Then population. Yes, population is a very important aspect of any study. So the population, that is the target population, has to be explained clearly in the title also. Let's look at this title, prevalence of depression in the elderly. So it has been mentioned, like here it is elderly. We are looking at a specific age. So that is one of the important thing that we can mention here. Looking at the second one, prevalence of osteoporosis in postmenopausal women. So here it is again population in females as well as, that age factor also is taken care of. Now coming to I, that is intervention, which is the key element of any study. So when we talk of intervention, it could be therapeutic or preventive. So we need to mention that in the title. Now let's look at this title, vitamin D supplementation in children with severe asthma, a randomized control trial. Now if we look at this title, we cannot we don't get an idea as to whether this is therapeutic use of vitamin D supplementation or is it preventive. So it has to be made very clear. The same title, if written for therapy, it could be effect of supplementation of vitamin D on the severity of asthma episodes. While if it is a preventive question, then it is the effect of supplementation of vitamin D on the occurrence of recurrent episodes of asthma. So this also has to be very specific. It's just not the intervention, but is it for therapeutic purpose or preventive purpose? So title should be very clear with that. So as we said, therapeutic effect of vitamin D in children with severe asthma randomized. It could be rewritten in this way. Now, in conditions where, or in studies where we don't have an intervention, like we have the observational studies where we don't have the intervention, in those cases, we could also mention the type of the study at the end as is written here. Serum vitamin B12 levels in adolescent Indian girls, an observational study. Okay. Now C stands for condition. Condition is nothing but it is a clinical condition of the subjects that we are looking into. Like for example, in this study, the pregnancy is the condition. Endpoints. Now endpoints are something like outcomes. Now when we are writing our synopsis, like for our dissertation, then we need not write about, we did not include the endpoints in the title, because if we do so, then it becomes a declarative type of the title. This can be taken care of or can be included when we are writing the paper. So used sparingly. Design, yes, definitely a very important part of the title. We have to include design in the title, and including such a study design makes the title complete, as we have seen again earlier. Serum folate levels in pregnant Indian women, and observational study. So usually here we use a colon or an M dash to mention the type of the study. Okay, so to summarize, these are the 7 secrets to writing the title of a research paper. Keeping it concise, specific, mentioning the place, making it descriptive, and appropriately spiced content. Okay, now how do we draft, after all this, how do we draft the suitable title? So what are the steps that we can follow? So the first thing we do is, first time when we are writing the title, you draft around 2 or 3 sentences containing the important scientific words, keywords, which describe the main contents and subjects of the proposal, avoiding the results, because as we have already discussed, as far as possible, avoid the declarative type of title, especially for synopsis and dissertations and theses. Now, after we do this, join all the sentences to form a single sentence. Now, you shorten it down by removing the redundant words or adjectives or phrases, and then finally edit it to make it more accurate, concise, limiting to 10 to 15 words so that it looks more precise. Now, this is how we write a suitable title. So again, this is just the summary of what we have discussed about the title. Now here I would like to stress that whatever we have discussed related to the title, like the spiced content and including the population, including the place, all these also hold good for the objectives. That is why I have just tried to cover it little in more detail in relation to the title, but all these also apply to the objectives where I will not be discussing much in detail. Okay. Now, one thing which I did not mention on purpose about the title is that the title of the project proposal or the paper must reflect the primary objective. Now, this is how the title and the objective, which is the second part of this session, are linked. So that whenever we are writing the title, we need to keep in mind that it reflects the primary objective of the study. So let's come to the research objectives now. Yes, often we keep using these two terms, aim and objectives, as synonyms. They are not the same, but yet they are related. So what is aim? Aim of any research defines the main purpose of the research. That means what are we doing? What is that we want to do? Like, for example, we want to look at the hypotensive effect of a new drug. That is the aim. I want to look for the hypotensive effect of the drug is the aim of a research protocol. But what is the objective? Research objective means what are the steps that we take to fulfill that aim? That means how are we going to conduct the research? Like, for example, if I say that the aim is to find out the hypotensive effect of the drug, then my research objectives would be to measure the blood pressure in a given situation, in a given population under various conditions. So that would be the objectives. So how we reach to the aim are the objectives. So why are these research objectives important? Yes, they are very important element of any research protocol because it is based on the research objectives. We identify the sample, we identify the methodology, to bring in that congruency between the objectives and the research methodology. So these objectives, they establish the scope and depth of the project. They also avoid unnecessary research and hence means that the research methods and the conclusions can be easily evaluated. Second, as I already said, it contributes to the research design. It helps us to, select the appropriate designs for a particular research question. It also indicates how our project will contribute to scientific, that is to science, that is the extant research. Okay. So what are the types of objectives? Now, usually most of the times we talk of two types of objectives, the primary objective and the secondary objective. Now, what is the primary objective? Primary objective is the one which mainly helps us to find the answer to the main hypothesis. Now, already the hypothesis has been discussed in one of the previous sessions. So we through a lot of literature search and a lot of, coming out with what are the importance of that topic, what has already been done, what has not been done, what is the need for the study, and finally with so many things we come up with a hypothesis, a research question and a hypothesis. So what the primary objective aims is, it tries to find an answer for the main research question. That's why it is called as primary. While secondary objective is the one which attempts to answer additional research questions that may arise while addressing the main research question. So it could provide additional information about the intervention or the exposure. It could also explore other research questions of interest. So having said that, primary objective, most of the time we try to limit it usually to one. What is the reason for this? Now, because when we are writing our primary objective or when we are writing the research hypothesis, it is based on some earlier studies which have been done. Now, if we include number of primary objectives, then, calculating the sample size also based upon the various previous studies do not match. So as far as possible, try to keep the primary objective as one. While secondary objectives could vary from 3 to 4, again, based upon what we are interested in, it could vary in numbers. Like, for example, it could be assessing the safety and tolerability of the intervention or the effect of the intervention on secondary outcomes, like it could be quality of life, adverse events, or subgroup analysis. So let's look at an example where our aim, as I already was stating earlier, an example where the aim is to determine the degree of hypotension of a new drug for induction of anesthesia. The primary objective would be to measure the fall in the blood pressure after its administration, that is administration of the new drug, and compare it with the fall or otherwise after administration of the agent already in clinical use. That means we are comparing it with the standard. While doing this, we could also concentrate on some data which we are seeing, or when we come across the data, or we expect that this could be possible. Like, for example, recording other adverse effects of the new drug, recording what is the duration of the onset of the drug, or interaction of this new drug with other anesthetic agents. So these could be the secondary objectives. So primary objective mainly answers your main research question, while associated things are answered by the secondary objectives. So for any research protocol, we could write primary as well as secondary outcomes or secondary objectives. So how do we write the research aims and objectives? So yes, we already know what the research question is, right? Now, once we are sure with our research question, the first step is to write the general aim. That's why we said, because the aims answer the research question. So this could be overarching, but it should be reflecting the research problem and is relatively broad. Now, from this broad general aim, we try to write our specific objectives, as already said in the previous slide. So when we have one aim, we could have the primary things which are answering the primary hypothesis, and we have the associated things which could be associated with the primary objective or the research thing. So what we do, we break down the aims into such different points. Once we do that, we start writing for each of such point, we start formulating the objectives, writing them very clearly and concisely using appropriate words. So how do we formulate this? Okay, let's look at the same example. The primary objective which I mentioned in the example here, to measure the fall in the blood pressure after its administration when used for induction of anesthesia, and compare it with the fall or otherwise after administration of an agent which is already in clinical use, that is the standard drug. So we use, the SMART protocol or format to write these research objectives also. So what is the SMART? So let's consider the example which has been written below here. The first thing is, yes stands for specific. Is the objective specific? That means, is it clear and well defined? Now, while deciding whether it is clear and well defined, we look at these, what we call as the PICO model. PICO means P stands for patient or the population. Does the objective has that? Okay, in our example down here, we definitely have, it is the population where we are going to use this new hypotensive drug, especially for those who are going for some type of surgery, who will be given some type of anesthesia. So that is the population of the patient. I stands for intervention. So we know the intervention here, it is a new drug that we are using. C stands for comparison. Comparison means, yes, we are comparing it with the standard drug. And O, what is the outcome? So what is the outcome in this example? It is a fall in the blood pressure. So to make it more specific, we can just look at these elements, the PICO elements, and make it clear and specific. Second thing, when we write or when we are writing the objective, is it measurable? Like, for example, here, measure in the to measure the fall in the blood pressure. Is it possible? Is it measurable? Yes, it is. That's why any objective that we write, it has to be measurable. Can this objective be achieved? And yes, is there a way to measure it? Third, very important is achievable. A stands for achievable. That means, do we have enough support and resources to fulfill these objectives, or are we over ambitious with the objective? So we have to be very clear here, because any research has to be feasible. It's always said, research is like small is beautiful. So yes, start building on smaller objectives, smaller studies, and then later it can be built upon. So a very important element of any research is achievable or feasibility. Next is relevant. R stands for relevant. Is this objective vital for fulfilling the research aim? And yes, again, very important is time bound, especially when this is for postgraduates, because as a part of their program, they have a limited time where they have to finish off with the studies. So is it time bounded? Is it realistically possible for us to finish it within the given time. So this is the smart format of writing the research objectives. Make it specific, let it be measurable, let it be achievable, let it be relevant to the study, and yes, time bound. So this is how we write. Now, in addition to this, as I've already mentioned, the particulars which we have discussed with the title also have to be taken care while writing the research objectives. So finally, while framing the objectives, you could have one or more, as mentioned, primary one as far as possible, could have 3 or 4 secondary objectives. Let them be few and focused, because if there are too many, then it becomes very difficult to manage. Especially this is when we are doing these protocols as a part of some programs like MD or DM. And yes, very important, changing objectives in the middle or the end of the study should be avoided. And therefore, I'm sure this has already been discussed, while making the research question, we should be very, very, very specific. So that's about how we frame the objectives in relation even with the titles. And as mentioned earlier, the primary objective has to be a part of the title. So that's all I have from here. Thank you very much for your patience hearing.
Thank you very much, Nayana ma'am. That was a very clear and comprehensive talk on how to draft a title and frame the objectives. Thank you very much. I think we move on to the next speaker. Now, having set the research question.
Shruti, I think we'll just take a minute out to welcome our guest.
Okay.
Special invited. Yes.
Right.
Sorry, Geetanjali, I joined earlier. I was listening to the earlier talks also.
Thank you, ma'am.
Very extensive. I think the postgraduates are very lucky that they're getting such excellent speakers to listen to. Because as postgraduates, we did not get this opportunity. We have to learn as we became clinicians. And that's a very, very tough job to do when you're doing clinical work. And especially the previous talk was so concise. Like it's not easy to speak on something which is like very abstract. But Dr. Nayana did such a beautiful job. And I request that the postgraduates do not get overwhelmed when they listen to all this. They have to take it piece by piece. Like once you start, you sit and think over, and then you do each part of it with interest. Then it comes to you. It will not happen in a single day. We have learned our subject over so many years, and you cannot learn it in an hour or so. But you have to keep on persisting. And when you do it, you will get such great satisfaction when you finish it, because with clinical work, when you're presenting data, it adds on so much value. And I'm enjoying all the talks. Thank you, Dr. Geetanjali, for the opportunity. Thank you so much.
Thank you, ma'am, for joining us despite your busy schedule. Your madam was involved with another webinar. Thank you so much for making time for us, ma'am, and providing your expertise to us.
Thank you, Geeta. Thank you.
Yeah, ma'am. I'll just take a minute to introduce our special guest who just spoke. She's Dr. Charmila Ayavu, ma'am. She's Vice President, FOGSI 2024, and past Chairperson, Clinical Research Committee, FOGSI. She's a ICOG Governing Council member, 2021-25, and also a National Coordinator for UNICEF FOGSI, Medha FOGSI PG Program, ISAR Gurukul Program. And Madam is also Secretary, Gestosis India Association and Academic Wing of Assisted Reproduction, Trichy, and also a Managing Committee member for PCO Society of India. We welcome you, ma'am. Thank you for your kind words.
Yeah, thank you, Shruti. Thank you so much.
Yes, we move on now, having chosen the research question, study design, and also drafting the title. Next, the big question will be the sample size, which will be most bothering to the postgraduate especially. So to talk on that, I invite Dr. Manjula R. ma'am. She's Professor, Department of Community Medicine, SNMC, Bagalkot. She is a resource person and a member of Medical Education Unit, and also member of Ethics Committee, SNMC Bagalkot. She has contributed many chapters and many publications to her credit. We welcome you, ma'am.
Thank you, Shruti madam, for her kind words. I'm going to share my slides. Is my slides visible, madam?
Yes, yes, it's visible. It's visible.
Okay, thank you, madam.
But make it slide share. Huh?
Good evening, esteemed.
Press the slide share option so that only one slide will be there.
Yeah, I have done that, madam. I have done that.
No, no,
we can still see it in a different view. It's not the slideshow.
Slideshow.
Slideshow, it is done, madam. It will take a while. I have done in my laptop.
Is it? Okay.
Okay. Good evening, respected esteemed members of Kasoga and Foxy. And at outside, I would like to thank for giving me this opportunity. And this particular scientific session, what you have planned, it is very timely and it is very you have opted a very right time for conducting such a meaningful workshop or CMA. As Palazar was saying, research while framing research, when we are doing a research, framing a research question is one of the important and first and foremost step in the research. So while framing a research question, we have to see that the research question should be finer in that while assessing the feasibility, that is F of the finer aspect, feasibility aspect, the sample size estimation is one of the important step in conducting the research. So while doing this sample size estimation, it is not just the arbitrary number or it is not just the magic number which will be provided for the researchers to conduct the study. There's a lot of calculations and background work will be done for estimation.
Now, confidence of the going with goods.
Which we are not very comfortable in as after entering our medical profession, we are not very comfortable in seeing the numbers. So we will.
Your slides are not moving, Dr. Manjula.
I have not changed, madam. Now I am changing. Is it
And,
now available?
No, it's not moving. Slide share also, it's not come actually. Can you try that icon there?
Manjula ma'am, is it okay if I share?
Yes, yes, please do that.
Okay. Can you stop sharing?
Yes.
Just a minute.
Yes, ma'am. Shall I proceed?
Yeah.
So today I'm going to present my session with the following headings. What is the importance of sample size estimation? Factors that are going to influence the sample size estimations. What are the different methods of sample size determinations? And how we are supposed to report the sample size statement in the methodology. Next slide, please. So what is the sample size determination? So it is, as I said already, it is the very important step in conducting the research. It is a portion or subset of a larger population used to make inferences about the population. It must be adequate to represent the population. If the sample is chosen carefully, which is termed as representative sample, the results from the survey will represent those would have been obtained from interviewing everyone in the population or census at a much lower cost. That is at 95% confidence limit. So what is this? Next slide, ma'am. What is this representative sample? So sample size, as I said, it is one of the important issue in quantitative research. Usually in qualitative research, we are not going to calculate sample size. Usually convenient sampling is done. Whereas in quantitative research, sample size estimation is very, very important. So why it is important? We tend to make statistically based generalizations will be done about the sample to the population from which the sample is drawn. So in order to generalize this sample or the results obtained from the sample to the representative to the population, so the sample should be representative, so that we should be able to extrapolate the results which are obtained from the sample to the general population. Next slide, ma'am. So here we see a picture of a population of interest and from which the sample is drawn, and we are going to estimate the statistic from the sample, and we are going to extrapolate the results to the population from which it is drawn. So the whatever the values we estimate from the sample, it is called as statistic, and whatever the values we are going to extrapolate to the population, it is called as a parameter. So next slide, we are going to understand what it is, what is the statistic and what is the parameter. Next slide, ma'am. Okay, you can see there is a population and we want to estimate the population mean. Say, for example, we are trying to estimate the population diastolic blood pressure. So when we draw the sample from the population, different samples, so we see that the mean blood pressure which is measured in each of the sample is different. It ranges from 79.6 to 88.3. So whenever we pool together these values, we are going to get the mean sample size of mean diastolic blood pressure of 82.4, which is almost nearer to the population. So that is the reason when the sample is drawn from the population, so the sample should be representative, and these values what we get from each of the sample, so might be little different from the population mean, but when we pool together, if the samples are representative, we are going to estimate correctly the population mean. So here we would have not done the estimation of diastolic blood pressure of the whole population, but only the sample is drawn. If the sample is drawn properly, we will be able to estimate the population mean properly. Next slide now. So now the sample size, how much should be the sample size? How much big and how much small? If the sample size is very small, we will not be able to get the valid results. We will not be able to get a useful results from the study. So it is a waste of resources. So suppose if you get, if you become over enthusiastic and take a very large sample, so we may get a statistically significant result with a doubtful clinical importance, leading to the waste of resources, and it is also unethical to take a sample which is larger than the required sample size. So we might have experienced this when we publish article and send a statement of sample size estimation. After doing a study, if we would have increased the number of sample size, they'll ask for the explanation. Why did you increase the sample size? Because sometimes in order to increase the power or increase the statistically significant results, we tend if the population, the sample size is increased, it is going to give a faulty results. So next slide. So you see the example here. So here, when the sample size is less, so the population mean and the sample mean, even if there is a statistically significant difference, so it is showing as statistically significant result. But suppose if you increase the sample size to 10,000, even with just minor increase in the population mean, it is going to show it as a statistically significant. So this is the influence of the sample size on the statistical outcome. So we have to be very careful when we are taking the optimum sample size when we want to estimate the results or any variables. It could be a proportions or the sample mean. So we have to have a optimum sample size. Next slide. So what is the importance of sample size calculations? So when we do a research, so we always want to show the statistically significant results. So we want to say that, okay, we have got a significant results. P-value is less than 0.05. So we are very keen on looking at the statistical significance difference, but whether the difference is meaningful or not, clinically significant or not, is very, very important. This consideration has to be done at the beginning of the study itself, so that if the clinically significant values are used for the calculation of the sample size, and if it is found to be statistically significant after the conduct of the study, then the study is useful. So if this clinically significant results, for say, for example, you have used a newer drug for reduction of blood pressure. So a reduction in 10 mm of Hg of diastolic blood pressure is clinically significant. So this measure of 10 mm of Hg should be taken into consideration for calculating sample size. And after doing a study, then if there is reduction of blood pressure of 10 or more than 10 mm of Hg of diastolic blood pressure, that will be reflected as statistically significant after the study is done. So when sample size calculation is done, we have to take all this information into consideration. We have to think. So some study would have shown reduction in 2 mm of Hg of diastolic blood pressure, but it may not be clinically significant. So such things we have to take into consideration before doing a sample size estimations. Next slide, ma'am. So already I told you the importance, the smallest clinically important significant difference, or the difference the investigators think of worth detecting. As I said, so by giving this newer intervention, whether we are going to achieve reduction of blood pressure of more than 10 mm of Hg. By doing this intervention, are we going to reduce cardiovascular event to about 10 to 20% in the population? So this should be determined before going for the calculation of the sample size. The difference that the investigator think is likely to be detected. So this is usually we are going to take the help of the previous literature or the previous research which is already done and published somewhere in the journals or from the references. Next slide. So what are the factors that are going to influence the sample size calculations? As the previous speaker, madam was rightly saying, so the primary objective is very, very important factor which is going to influence the sample size. The sample size calculation, usually it depends on the primary objectives. Sometimes if we have objectives which are secondary objectives, which is also very important, so we will have to calculate the sample size for the secondary objectives also, and we have to take the larger sample size which is going to answer both the primary and secondary objectives. Say for example, the primary objective, the same example what the sir was taking, the use of prophylactic tranexamic acid in prevention of postpartum hemorrhage. So if we can use the sample size estimation for knowing what is the percentage of patients who are going to be treated effectively by giving this prophylactic tranexamic acid. So that is fine. So that is a primary objective. We can take that into consideration for calculation of the sample size. What are the secondary outcomes? Is there any side effects due to tranexamic acid? Recently, we found that the mefenamic acid, which is from the same family, the drug, was found to be associated with one of the adverse event like neutrophilia and the idiopathic neutrophilia. So we can also look for, okay, whether this drug also causes this kind of adverse events after using it for treatment of PPH. That could be a secondary outcome, the adverse event following the tranexamic acid. So again, the type of outcomes what we have, again, that will also be taken into consideration for calculation. Categorical outcome or continuous outcome. The example for this is what percentage of women who are prone for PPH could be prevented by giving a tranexamic acid when compared to the other group. And it could be continuous also, or a quantitative data, qualitative and quantitative data. So what is the amount of blood loss following the use of tranexamic acid and when compared to the other methods of treatment? So what is the clinical relevance of the outcome? So while using this outcomes, is there any clinical relevance? So we can use that all the factors into consideration for the calculations of the sample size. And again, the intervention groups and the control groups. How many intervention groups we have? Do we have a control group? Are we going to have interventions for different doses? Again, that will also influence the sample size calculations. Next slide, ma'am. Factors that are going to again influence is this research design. So the study design, what we are going to choose, whether we are going to use a cross-sectional study, the analytical study designs, whether we are going to use simple randomized control trial, or we are going to do cluster randomizations, or whether we are going to use different types of RCTs like superiority trials, inferiority trials, equivalence trials, sometimes non-randomized intervention studies, studies for measuring sensitivity and specificity of particular newer diagnostic tests. So we again, all these things it should be taken into consideration for calculation of the sample size. Next slide. Whether we are going to randomize the individuals and the clusters, again, very important. So we are going to take into consideration whether we are going to use individuals for randomization or the groups for a randomization. For randomization of the clusters, there is something called as design effect, which should be taken into consideration for calculation of the sample size. When we use clusters for randomization, we are going to increase the sample. Okay. So clusters randomization, we include the groups for randomization, and it is going to help in randomization. I was just taking that example because that was used for that is the literature search, the tranexamic acid. I was just taking it as an example. Okay, sir. Thank you, sir, for that. And also, what are the methods of statistical analysis we are going to use? Again, that should be taken into consideration for sample size estimations. Next slide, ma'am. So again, while calculating and estimating the sample size, so we have to take the response rates and last to follow-ups of the sample also into consideration. So there is something like correction for last to follow up and correction for last lack of compliance. So that should be done for the estimating the sample size. So the number is going to increase little bit from 10 to 20% depending upon the type of the study subjects, whether there is any possibility of follow-up, whether there is a possibility of compliance. That again, that should be taken into consideration. If there is the follow-up last to follow-up is more than 20%, then usually the study is going to give less power. The results what we are going to get out of such studies is not very clinically relevant. So in such cases, we have to do something called as intention to trait analysis, and we have to see whether the results can be used for the evidence or not. Next slide, ma'am. So the characteristics of the good sample should be representative. It should be easily accessible, and also it should be full. Economically feasible, and the chances of error should be very less. So there is something called as the errors that can happen in the research, that is falsely accepting the null hypothesis and falsely rejecting the null hypothesis. That is the two types of possibilities that happens when we do a research. There is nothing like absolute. So we are doing a research and we are going to get 100% correct results. That is not going to happen in our in the field or in the research, whatever it is. There is some amount of errors that are going to happen. So we are going to accept the minimum error while doing a research. So these errors are called as type 1 and type 2 error. Next slide, ma'am. Okay. So here we have decision what we are going to make and what is the reality in the field or in the research or in the study subjects. So we tend to make certain errors when we make a decision or statistical decision process. So that is type 1 error, that is false positive error, that is falsely you are telling the patient is positive for the disease or positive for any of the event. And type 2 error is falsely you reassuring the patients that the patient is not having the disease. Such thing can happen in any of the situations, the type 1 and type 2 errors. So these errors has to be kept at minimal when we do a research. So these errors can be controlled or can be managed by during the process of sample size estimation, which is going to take care of these errors, type 1 and type 2 error. Next slide. So this error, to make it simple, so I have given you this slide. Type 1 error, false positive, where male person is being told that he is pregnant. And again, type 2 error, false negative, and saying that lady is not pregnant even though the fetal parts are seen in the ultrasonogram. So these errors, false positive and false negative errors, it will happen and it should be kept at minimal when we do a research. Next slide, please. So what will happen if you control the type 1 error? That is going to help in increasing the significance. So when we do a research, the significance level should be at least 95% and the error should be below 5%. This is the acceptable type 1 error. That is, your type 1 error should be less than 5%. It should not be more than 5%. This is the minimum acceptable error that we are going to accept. It should not be more than 5%. That means to say that whatever the difference we have found in the research, the difference in the effect of the drugs or difference in the risk factors, what we have found in the different two different groups, that is cases and controls, this difference is actually true to up to 95%, but only 5% we are not sure. That is the error, type 1 error. So when we keep the type 1 error less, so the confidence level will increase, and that is called as significance level. Next slide, ma'am. So type 2 error is, by controlling the type 2 error, we are going to improve the power of the study. So this, while doing a research, the type 2 error or beta error should be kept below 20%. It should not be more than 20%. That means to say that the power of the study will be 80%. So power of the study is equal to 1 minus beta, or when you control the beta, so the power of the study will improve. So the power of the study is the probability of rejecting null hypothesis when the null hypothesis is false, or the probability that the test will correctly identify a significant association in the sample. The power of the study is ability to detect the actual difference that is there in the research. So this beta error should be kept at less than 20%, and such that the power of the study will be 80% or more than 80% if the beta error is kept at below 20%. Now the next question is how to control this type 1 error and type 2 error while doing a calculation of sample size. Next slide. So there is a Z distribution values for different significance levels and also different power of the study levels. Suppose if the significance level is at 5%, the Z distribution value is 1.96, and if the 80% for the 80% power, so the Z beta value will be 0.84. So these values are for two-sided analysis. So we always do a research with an open mind whether the research might give a positive or a negative result. It can happen in both the ways. So that is two-sided analysis. So this Z alpha and Z beta, how it is going to influence on calculation of the sample size. So when we do a research and when we do a statistical analysis, for the values what we calculate, whether it is a chi-square value or a t value or a z value, these values we are going to check in the Z distribution table for the level of significance what we have got. So now that we have the softwares which will provide us the Z values, chi-square values and t values and all. So how will you get this p value based on the result what we get after doing a statistical analysis, that is based on the Z distribution table. This Z alpha value and Z beta value, what I'm saying, it is the Z correspondence value at the level of significance of 95% for alpha and 80% of the power, the Z beta value will be 0.84. So now, where do we use these values in the calculation of the sample size? Next slide, ma'am. So this values, I'm going to show those Z alpha and Z beta values when I show the formulas for calculation of the sample size. So when sample size estimation has to be done, first we have to know the specific hypothesis, and we should know the objectives, of course, and also there are formulas, different formulas for calculating the sample size for different tests and different hypotheses. So when we are doing a sample size estimation, we need to calculate the sample size for different assumptions. Say, for example, where we have a primary objectives and the secondary objectives, and like we may want the results very precise and not very precise, how much precise results we want. So all that things taken into consideration for calculating sample size. After that, we have to pick the most optimal sample size for our research. Next slide, ma'am. So already I told you, sample size calculation is based on the primary outcome, and again secondary outcome should also be taken into consideration if it is very important. And again, the sample size should be sufficient for answering both the primary and secondary objectives. Next slide. So this for calculating the sample size, we need to know the values for calculation again. So suppose we want to estimate the study for knowing the prevalence of postpartum hemorrhage in pregnant women. So we want to do this study. So where will you get the value for calculation of the sample size? It is from the published data, or previous work, or review of records, expert opinions, or by doing a pilot study. So suppose if we want to do a study on effect of a new drug on reduction of blood pressure. So how much reduction of blood pressure has been seen by the previous researchers, and the same data we can use for our study to see like whether in our study subjects whether we are going to get the same kind of results when it is compared with the other drugs. Again, the same similarly, if you want to do a study on the reduction vaginal infections as a risk factors for preterm deliveries, these are some of the studies which our postgraduates have done, and had to do a sample size estimation. So this proportion we have to take, like what is the proportion of vaginal infections which is contributing to preterm deliveries. So we can use from the previously published data for calculating the sample size. Next slide. So when we do a research, when we do a study, there will be outcomes in terms of estimation of the proportion or prevalence, estimation of the population mean, difference between the two proportions, and difference between the two means. So to give example, again I gave you the example, estimation of proportion. So what is the proportion of PPH which is attributed to uterine atony? So that could be a proportion, or proportion and prevalence we use interchangeably for calculating the sample size. What is the prevalence of hypertension in bank employees? So this value will be taken into consideration. Estimation of the population mean. So I gave you the example already. Estimation of the diastolic blood pressure in the community. So in particular age groups, say for example, those who are above 35 years or 40 years. So population mean we can take for calculation of the sample size. Difference between the two proportions. So the example, again, I would like to take the same example, which is the research done in our in our college by our postgraduates. That is prevalence of gestational diabetes in prophylactic iron supplemented pregnant women who are already anemic, and prevalence of gestational diabetes in prophylactic iron supplementation in non-anemic pregnant women. So these two proportions will be taken into consideration for calculating the sample size. So we want to know the difference in two proportions. Again, difference between two means, like say for example, what is the duration of surgery by two different methods of the surgeries, or difference mean and standard deviation of post-op analgesic consumption following two different anesthetic drugs used, or difference between the amount of blood loss by using two different drugs for postpartum hemorrhage. So these values will be taken into consideration for calculating sample size. So from the past research articles. These are the common circumstances, but there are some conditions where we are going to use. Hello, madam. Hello. Okay. Sorry. So these are the different circumstances when we are going to do a sample size estimations. Next slide, ma'am. So for estimation of the proportions or prevalence, we use this formula, which is very popular, that is 4PQ by L square. So we use proportion or prevalence from the previous literature, and Q will be 100 minus P, and L will be the allowable error, how much error we are going to accept for calculating the sample size. Suppose if the prevalence of the PPH in vagina in PPH, if you want to study how much error, if it is the prevalence is say for example 8 to 10%, so how much error we are going to accept while doing a research. That means if it is 2%, so we will get the result anywhere between the 8%. If you take it as 8%, 6 to 10% the results we are going to get if we take the error as 2%. So this error, it is how it is going to influence on the sample size. I'm going to say in the next slide. Next slide. See here, taking this example, prevalence of hypertension in bank employees. Say for example, if it is 50%, if the allowable error is 5%, the sample size is 400. Suppose if the error is 10%, if we accept the error as 10%, the sample size is reduced as 100. So the researcher has to decide how much precise the result should be, and based on that, the sample size will increase and decrease respectively. Many times the PGs, they will ask for reduction in the sample size, but it happens by compromising the errors. Next slide, ma'am. This is again the sample size for finite population. We use the different formulas. Next slide. This is again example for the same with the same example, how the precision is going to influence on the sample size. Next slide, ma'am. So estimation of the population mean. So again, this we use the formula like n is equal to 4 sigma square by L square. So again, the the precision, it depends on how much precision, the sampling defects or precision we are going to tolerate, that we should be that will be taken into consideration for calculating the sample size. Next slide, ma'am. So this is the sample size estimation formula for a difference between two proportions. I was giving you the example. So we use this value, that is 2z alpha plus z beta whole square into p into 1 minus p by delta square. This z alpha z beta square, this is the constant values what I was saying in the for controlling the alpha and beta error. So in the previous examples, that is 4pq L square, it is actually a z alpha square pq by L square. So when we multiply 1.96 into 1.96, it will be 3.84. In order to make it simple to remember easily, it is made as 4. So there z alpha square will be taken into, z alpha square is the actual formula for estimating the proportion and mean. So this z alpha and z beta is a constant for a given significance level and the power of the study. So again, that will be taken in for calculating the sample size. Next slide, ma'am. Again, for the quantitative outcome between the two groups, this is the formula what we use: 2z alpha plus z beta whole square, sigma square by delta square. So next slide, ma'am. So these are the different formulas which are used for different types of studies, especially RCTs like equality, non-inferiority, superiority, and equivalence studies. So right now we do not use all these formulas manually, but we have softwares for calculating all this sample size. Next slide, ma'am. So how this sample size calculation has to be reported. So the sample size estimation will be done by a statistician or a researcher, the community medicine specialist who is trained for doing all this. So when they give how you're supposed to report, so there should be a clear statement of the primary objective in the methodology. There should be the desired level of significance, what you have decided, what is the power of the study, what are the statistical tests we are going to use for the analysis, whether the test will be one-tailed or two-tailed. So that should be taken, that should be mentioned. Along with that, what is the smallest clinically significant difference we are going to detect by doing this research? Again, that has to be mentioned. Next slide, ma'am. So when we report a sample size, we have to report, we have to say the estimates, what prior information we have taken for the calculations, which study, the difference, which study we have taken, where it is published. So again, that has to be quoted and that has to be mentioned in the reporting. And there should be a clear statement about the assumption of normal distribution, clear statement about the scheduled duration of the study, and statement about the sample size adjustment for loss to follow-up or non-compliance, and also the software or what is the formula used for the calculation. Again, that has to be reported. So this sample size reporting is very, very important, and it is explicitly it has to be done in our research, and it is mandatory for getting ethical clearance, and also after doing the research for publication, all this information has to be reported. Next slide, ma'am. Sometimes some statements like this, it is a rejected sample size statement. Say, for example, somebody says that the previous study, they have recruited 150 and they have found a very significant results. Can I use the similar sample size for my study? So you should not make such statements when you are reporting a sample size. The sample size estimation is a scientific method, and it has to be estimated and calculated properly, and it should be reported. So it also should not be based on the available patients. I get 100 patients, and I'm going to use only 100 patients for my study. No, it should not be this the thing. Next slide, ma'am. So suppose if there is no prior information, if you're doing the study on a if you're doing a new study, so we can conduct a small pilot study, small pre-study. Usually for pilot study, sample size calculations are not necessary. Based on the results of the pilot study, we can estimate the sample size. Next slide. So pilot study is a preliminary study intended to test the feasibility of the larger study, data collection methods, collection of information, and also sample size calculations. So it is a small number, and it is not going to give us any scientific information except for knowing the feasibility and calculating the sample size. Next slide. These are the softwares which we use regularly for calculating the sample size: OpenAP, SPSS, StatCalc, APinfo, etc. Next slide. Okay, thank you, ma'am. Thank you for the opportunity. And this is about the sample size estimations. If there are any doubts, I'll be happy to answer.
Thank you very much, ma'am, for that elaborate information on the sample size. I think we are running short of time, and we should move on to the next speaker. That is Dr. Manish Barwalia. He will be speaking on the basics of data analysis. Sir is the head of the Department of Health System Research at ICMR, National Institute of Traditional Medicine, Belgavi. He is trained in clinical trial management, pharmacovigilance, health economics, and he is associated with various phase 3 clinical trials and also research projects. And he also has many publications to his credit. We welcome you, sir.
Thank you, Dr. Shruti, for my introduction. And I would like to thank Dr. Geetanjali and Karnataka State Obstetric and Gynecological Society for giving me this opportunity to speak with the future of India. And I'll be keeping my session to the point and short, because most of the things, basic things regarding even biostatistics have been covered by previous speakers. So why biostatistics? I'll be covering. Is my screen visible, ma'am?
Yes, sir.
And slides are moving also, right?
Yeah, they're moving.
Yeah. Okay. So I'll be covering why biostatistics. What are the basic terminologies which everyone should keep in mind? Types of data, measures of central tendency and variance, and data distribution, and how to choose statistical test for analysis. So just if I want to ask people whether he is tall or short, then somebody will tell he is tall, somebody will tell he is short, but somebody may tell that there is no comparator, there is no background data also. So whenever we are working in clinical setup also, we are having this kind of clinical observations, which may need to be converted into objective parameter. So now if I add comparator, then everybody will tell that this person is short as compared to this one. So who is tall? This is clear-cut comparison. But when we talk about population or sample taken from population, then we need to do some calculations also, and we need to check the average and other parameters. So that I'm going to cover. Why biostatistics? As I came to know that most of the PG students are from gynecology. So yes, the knife is to the surgeon. So biostatistics is for medical research. So this is main thing. When you can measure what you are speaking about and express it in numbers, you know something about it. So that is why biostatistics is required in medical research. Otherwise, if somebody is telling this patient is having mild disease, so what is mild, that is defined in medical literature for particular disease. So how we have defined it? So by conducting some research work and objectively measuring those parameters. So why biostatistics? Because we are having now evidence-based medicine era, where we are having certain comparison between intervention A, intervention B. We are measuring biological effects very frequently now. We are into the research, and research needs to be with some objective parameters. So that's why we require some numbers also to measure the biological effect. While conducting review of literature, we have to we have to compare the review literature based on the statistical data only. So what is biostatistics? I think that is also covered by previous speaker. Statistics when applied to biological discipline. So whenever we are measuring the biological effect by applying mathematics or statistics, it becomes biostatistics, and it covers collection, data organization, data analysis and data presentation, and finally the interpretation of data. So there are certain basic terminologies. What is data? Data is actually observation of a variable. So another question is, what is variable? Variable is characteristics to be observed. So variables, for example, if gender can be considered as variable. So what we are going to check, whether male or female or transgender, so that becomes data. So again, height is a variable, weight is a variable. When we measure height and we measure weight, then that measuring unit will become data. Then population, already previous speaker has covered that there is population from which we exactly draw the sample by either by appropriate sampling method. So population is a group of people from which we draw the sample. Sample is representative of populations. So when we have representative sample from the population, we can generalize the data to that population. So that is the main idea behind this sampling from the population. So ideally less than 30 is considered as small sample size, and more than 30 is considered as large sample size, but it may be based on study design. If you are conducting some observational studies, sometimes if you are conducting this equivalence or non-inferiority trial, equivalent trial, then there may be large sample size that may reach up to 500, 600, even sometimes in population-based studies, it may go up to 10,000 also. So now when you are dealing with biostatistics, this is the basic step where you need to understand types of data. So there are mainly data is divided into two types: qualitative and quantitative, or quantitative and categorical. So quantitative data, either we can count it or we can measure it, then it becomes quantitative data. So for example, asthma attacks per week. So we can count, okay, how many attacks were there for asthma in 1 week. So either it will be 2, 3, 4 or 0. Same way, measured, when we can measure some parameter, then it becomes measured quantitative data: height, weight, blood pressure, blood sugar, okay, hemoglobin level, like that. Categorical data may be nominal or binary data. That means answer is either dead or alive, like that. Okay, ordinal data, which has some order in measuring, like mild, moderate, and severe data. So mild means we know that mild disease means it is of lower risk, moderate means moderate risk, and severe disease may be having higher risk. Okay, so that order is there, but that is again categorical type of data, but it will be in order, either from increasing order or decreasing order, like that. So all these things will be important, right? Because type of data determines the statistical test you are going to choose. Measures of central tendency, actually, when we have the multiple numbers of observations, either we are presenting them in mean or median most of the time. So we all know the definition of this. Mean means average, means we have, suppose 10 number of observation, we'll have a individual summation of observation, and it will be divided by number of observation. Median is middle value in the data set. So we'll be arranging data in increasing order, and then whatever the middle number is, that will become the median. And mode is most frequent value in the data set. So here I have one data set. If you see, this data set is arranged in ascending order, and middle value is 6, so that becomes median. Okay, and this is the most frequent value in our data set, so 2 becomes mode, and mean is summation of all this individual observation divided by number of observations. So 58 divided by 9, so mean is 6.44. Okay, then whenever we have this multiple observation, it's not like that everybody is having observation like mean is 6.4. So everybody's observation are different, but average value is 6.4. So now what is standard deviation? Standard deviation means how much each value, suppose 2, 2, 4, 6, 9, 12. So these values for individual person observations are there, but our mean is 6.4. So how these individual observations are differing from the mean or how they are away from mean, that defines the standard deviation. Okay, so suppose 2 is away from, so 4, it is away from our mean. It is lesser, 4.4 unit lesser than the mean. So that is standard deviation. 12, so that means it is 5.6 plus than the mean. So that becomes standard deviation. Standard deviation usually we calculate for the sample, whereas standard error of mean represents the population. So population is actually from where we have drawn the sample. So when we are drawing the sample, ideal way to present our data when we are presenting it in mean along with standard deviation, not standard error of mean, because standard deviation is little bit high in value. Standard error of mean shows lesser value. So most of the times researcher thinks that I don't want to show more variation in my data, so they will represent data in with standard error of mean. So that is wrong practice. Whenever we draw the sample, it should be presented with standard deviation, not standard error of mean. Standard error of mean is actually representing the deviation from population mean. Confidence interval, already previous speaker Dr. Manjula speak about alpha error and beta error also. So when alpha error is false positive, so this confidence interval is actually related to alpha. When we set alpha error 5%, then our confidence interval will be represented as 100 minus 5, that is 95% confidence interval. Here also majority time researcher makes mistake. If they consider alpha error as 1%, then their confidence interval should be presented as 99% confidence interval. So what confidence interval exactly shows or means? Mean. Okay, so actually if you consider this confidence interval, there will be lower confidence interval as well as higher confidence interval. So there will be range. So this 95% confidence interval will suggest that if you will repeat your study with same method, same population or same sample in same manner, then there will be a chance that you will get your 95% observations within this range only. Only 5% of observation will be outside of this range. So this is the equation. No need to remember all these things, but you need to remember that standard deviation represents sample data and standard error of mean represents population mean. So these are the things. Then comes the distribution of data. Distribution, most of the time, see, when we consider average mean and plus or minus 1 standard deviation, it will cover 68.26% observation that we have learned in community medicine during the MBBS classes. If we consider 2 standard deviation, it will include 95% of our observation. And when it is 3%, 3 standard deviation plus or minus 3 standard deviation will include 99.7% of observation. So now when when mean is near to median, that distribution is known as normal distribution. We all have learned that bell-shaped curve, okay, shows the normal distribution when we have data distributed on both sides of mean in proper manner. When there is a big difference between mean and median, it is known as non-normal distribution or non-normal data or skewed distribution data. This is again very important because whenever you want to choose your statistical test, this point comes into the picture. Because when data is normally distributed, we use generally parametric test, statistical test, and when data is skewed, having skewed distribution, then we use generally non-parametric test. Whenever data is normally distributed, we usually present data into mean. Whenever data is having skewed distribution, then generally we present data into median interquartile range. So this is the main difference which we have to consider while choosing a statistical test. So parametric, when we have parametric test or when we should use the parametric, first is when data is numeric. So when we have seen the types of data, either quantitative, numeric or categorical. When data is quantitative, then this parametric, non-parametric comes into the picture. Distribution of underlying population is normal, means data is normally distributed, normal probability plot, that is bell-shaped curve. And we have certain statistical tests also which actually suggest whether our data is normally distributed or not. So this test are Shapiro-Wilk test and Kolmogorov-Smirnov test, which actually we are using the softwares to determine whether our data is normally distributed or not. Skewed data can be transformed and then analyzed with parametric, means generally we do non-parametric test for skewed data, but with the advanced help of statistics, we can transform this data into normally distributed data that actually even I don't know, but we need help of proper biostatistician. And it is known that if we have large samples, particularly when more than 100 sample size is there per group, then most of the time data approximate a normal distribution, and we may analyze data with parametric test. So these are the points which you should always keep in mind. When we have quantitative data, whether counted or measured, when normally distributed, we present them with mean. When it is not normally distributed or skewed data, we present them with median. Okay, when categorical data is there, either nominal, generally we present with frequency. Ordinal, mild, moderate, and severe, again, we can present them as median data. So, earlier, all the speakers, while taking this research question or whether objective or whether study design, they have mentioned about two things, descriptive and experimental, or descriptive study design also, or analytical study design. So same way, statistics also have the same things, descriptive statistics as well as analytical or inferential statistics. So in descriptive statistics, when we have descriptive study design, we generally summarize the data. Okay, this many percentage of patients are having this many characteristics. Okay, so likewise, we summarize the data. Generally, statistical tests are not applied until unless they are divided into some categories and we frame some subgroups. Otherwise, generally, there will be descriptive statistics, just a summarization of data, which will be through measures of central tendency and variability. There will be no meaningful interpretation of data with descriptive statistics. But in case of inferential statistics, we will have application of statistical test. We will have comparison between parameters, and then we will have some interpretation for the data that will actually guide us for even this clinical practice policies also. Likewise, earlier speakers were mentioning about various trials for the various gynecological or obstetric conditions. Okay, hypothesis already Dr. Manjula has covered. Null hypothesis and alternate hypothesis. So I'm going to skip this. Already she has also covered that this hypothesis testing is error prone. Already she has mentioned that alpha error and beta error. These two errors are important because these two determines the sample size calculation also. So cutoff value for alpha, maximum alpha error we can allow is up to 5%, not more than that. But if you want to reduce it, you can reduce it, but your sample size will increase. So alpha value, if you are keeping at 5%, then your p value should be less than 0.05. That should be statistical significance. If you are setting your alpha error at 1%, then you should measure your statistical significance at p value less than 0.01. So that p value also is related to alpha. Okay, then beta is actually, it falls negative, but 1 minus beta denotes the power of study. So cutoff value for beta is 20%, not more than that error can be allowed in the study. So power of study, maximum power or minimum power of study required to prove the hypothesis is 80%. So both are important determinants for sample size calculation. Already madam has already discussed this. Even I have given the same example, but madam shows a wonderful picture of male becoming pregnant and female not. Okay. So p value, what is p value? P value is probability of getting observed outcome by chance. So if your data or if your statistical analysis shows that p-value is greater than 0.05, then whatever difference you have got, that may be because of chance. That may not be the true difference. And most of the times we consider two-tailed p-value until unless we have one side observation. Then what we mean by two side, we divide this 5% into two half, 2.5 on one side of mean and 2.5 on other side of mean, negative and positive sides. So if it comes in that area, that means our hypothesis is not proved. We have to reject the null, we have to accept the null hypothesis. There is no difference in the two groups. So now what are the steps for choosing this statistical test? So first, already I have discussed, it depends on mainly three factors: types of data, whether you have quantitative data or categorical data. Then distribution of data. If quantitative data is there, then we have to check whether it is normally distributed or it is non-normally distributed. So that we will going to decide with the help of some statistical test, particularly KS test or Shapiro-Wilk test. Aim of the study and number of group in the study. So we will show, we will just see this with the proper examples. So we have to look into the aim of study also, whether we want to find a difference between groups. Suppose you are giving two intervention for anemia, A and B. So you want to find difference between these two groups. That is your aim. So that will become unpaired. Unpaired means these two groups are individual and they are not related to each other. Same way to find a difference between groups, but paired data. Paired data may be before after kind of observation. Before giving any medication, this was the hemoglobin level, and after giving 3 months of this medication, what is the hemoglobin level? So this will be in same individual. Here it may be different individual in unpaired data. Then whether you want to find out an association between two variables. So now see, if our aim is to find out difference between two groups, that is not related unpaired data, then what we will first check whether types of data, whether it is quantitative, or if it is quantitative, then again, how many groups are there? Two groups or more than two groups. Then N stands for normally distributed data, and N stands for non-normal distributed, means skewed data. So suppose our aim is to find out difference between the group, unpaired data, types of data. If it is quantitative, means we can measure or count how many number of groups are there. Based on that, again, we have to look the distribution of data, whether it is normal. If it is normal and two group, then it will be unpaired t-test. That will be considered as parametric test. If it is more than two group, one way ANOVA is the test. If non-normally distributed data, then non-parametric alternative for unpaired t-test is Mann-Whitney test. Then here, instead of ANOVA, it will be Kruskal-Wallis. When we have more than two groups, then this primary analysis will be followed by post-hoc test, because this will just show that there is difference between more than two groups, but which two groups are different, that this test will not be able to tell. So whenever you are applying ANOVA or Kruskal-Wallis, it will be followed by post-hoc test. There are multiple post-hoc tests that we have to apply. If data is qualitative, then we have to check whether two groups or more than two groups. If it is two group, then Z test or chi-square test or Fisher-Exact test we can apply. Or if even more than two groups, then for this qualitative data, most of the time we apply for we apply a chi-square test. So here is the example. If a patient with refractory schizophrenia receives two type of drugs and primary outcome is number of subjects with decrease of at least 20% of PANS score, that is positive and negative symptom score. So here subjects with a decrease of at least 20%, means at least 20% and less than 20%. So there are two categories. So this type of data is categorical data, not numerical, even though categorical data will also be presented into number. Okay. So this is categorical data. How many groups are there? Two groups are there. So once categorical data is there, we will not take we will not check the distribution. Here, there are two different groups. So unpaired data is there. So it will be Mann-Whitney U-test or chi-square test. So it will be chi-square test because this is categorical data. Mann-Whitney U-test is for quantitative data. So this is the example. And if we have calculated based on chi-square test, p-value is 0.24. That is not significant. So there is no difference between this two groups. So there is no meaning of adding risperidone into clozapine treatment. So again, another example, fasting blood glucose level. So this is, we can measure. So this is quantitative data. If quantitative data is coming into the picture, then we have to check distribution. If it is parametric, it will be unpaired t-test. If it is non-parametric or skewed distribution, then it will be Mann-Whitney U-test. Same way, if paired data is there, again, same way we'll be looking into types of data. If we have quantitative data, again, we'll check how many number of groups are there. Then if quantitative data come into picture, we have to check the distribution. If it is normal distribution, paired t-test will be applied. That there it was unpaired t-test. And alternative to paired t-test for non-parametric is Wilcoxon. Same way here, instead of one-way ANOVA, repeated measures ANOVA, there will be multiple time points. Suppose I am checking hemoglobin level at baseline at 15 days, 30 days, 45 days, and I want to check that whether at what time point hemoglobin level is significantly increasing. So that in that case, it will come in this observation will be from same individuals at different time points. So alternative to this repeated measures ANOVA non-parametric is Friedman test. And again, we have to remember then when there is more than two groups, this will be followed by post-hoc test to check which two time points or two observations are differing from each other. If it is qualitative, then two group, then we have to go for McNemar's test. And if it is more than two groups, then it will be Cochrane's Q test. So effect of anti-diabetic drug on FBS, fasting blood sugar before giving medication and after giving medication. Okay, so this is the observation. So now fasting blood sugar is the quantitative data. We have to check whether it is parametric or non-parametric. If it is parametric, it will be paired t-test. If it is non-parametric, then it will be Wilcoxon test. Then if aim is to find out association between two variables, then we have to check type of data again, quantitative. Both two variables, both are parametric, means both data are normally distributed, and otherwise either one is not normal or both are not normal. Then accordingly we'll have Pearson's test, and if not normally distributed, then Spearman's or Kendall's tau test. Same way for qualitative, if table is 2 by 2, because two variables are there, so we will be calculating either risk ratio or odds ratio. Particularly in cohort study, we go for risk ratio, and case control study, we calculate odds ratio, and otherwise chi-square for trend regression. So the commonest example which is given in community medicine textbook PARC is association between smoking and lung cancer 2 by 2 table. So whether this habit of smoking is associated with lung cancer or not. Okay, so this is the data. This is how we present. Okay, so if it is cohort study and we are looking it into, okay, smokers whether develop lung cancer or not, so exposed, non-exposed, like kind of thing, then we calculate risk ratio. If it is case control study, already this lung cancer is there and we are checking the history of smoking, then it will be odds ratio. So this is the table which summarize everything. Quantitative data, groups are 2, unpaired, then unpaired t-test. If distribution is skewed, Mann-Whitney test. So likewise, we already discussed. I hope now based on this table and discussion, you can choose a right statistical test. At the end of my presentation, I'll just show you the demo also. Okay, so the important part for data analysis is to begin with proper data entry plan. So whenever you want to do data analysis with statistical software, you should have clear data entry plan from the beginning, that who will do the data entry, where it will be entered, whether it will be in MS Excel sheet, how you will be entering it, whether how you will check that data is valid, verified, accurate, and secure data. You have to create some data coding also, like you can't enter male, female, because otherwise if you do spelling mistake, it will be difficult to analyze, and statistical software will also not consider this type of alphabets. So 1 for male, 2 for female, 0 for no, 1 for yes, that kind of coding we have to make. Then you may have to do data cleaning also. You have to verify the data. You may have to remove duplicates also. That those things is important part of data entry. Handling missing data, how to handle missing data, whether that actually should be defined while writing the proposal itself, whether you will be carry forward the last observation taken. Then standardizing the format and uniformity in the data. Sometimes see age in numbers, just only you should not write 1 years, 2 years, and only number you should provide. Otherwise, this Excel sheet cannot be imported into statistical software. Of course, when you enter the data, you should ensure regular data backup, and quality should be ensured by checking the data with CRF or source data. That is very important task. So we don't need to worry. See, if the statistical test concept and all these things, we don't need to learn. You just need to learn only what kind of statistical test is appropriate for your data analysis. Otherwise, everything will be done by this software. SPSS, GraphPad, SS, AP Info. SPSS requires some specific training. SAS also requires some specific training. But I have found one very important calculator kind of software that for beginner is very important. So key message from my presentation is you should learn at least basic statistics. Softwares are there to do the calculation, but interpretation is our intelligence. One example I would like to give here. One PG student came with that. He did study with anti-epileptic drug, and anti-epileptic drug was increasing whether anti-epileptic drug increases liver enzymes or not. Then at baseline, that was his normal value or baseline value was around 30, SGPT was 30. Then it increased up to 53. Statistical analysis showed its significance, but whether it is clinically meaningful, no. So statistical difference may be significant, but clinical meaningful difference we have to interpret. So that's why interpretation is our intelligence. Softwares can do just a calculation. So I would like to acknowledge Dr. Nitya Gokte and Department of Biostatistics, from where actually I started learning my statistics. Thank you. Ma'am, if you permit for 2 minutes, I would just like to give a short demo of that software that students can do by their own. So this is the software. See, once you open this, it shows like this: compare means. This is GraphPad Instat software, readily available, freely available. The only drawback is that you can't save the data and you can't copy the data. So that's why you have to take a screenshot. So whether you want to compare mean, what kind of data you want to enter. Okay, here they have already listed the test also. Now just I am moving ahead. Now I have dummy data sheet also. Okay, I have hemoglobin level. Suppose this hemoglobin level, 2 column I am adding right now just to show you. I have copied this data. Okay, then I just have to, so I have copied my data, then I just have to click on next step. Okay, now see, just clicking on next, I have mean, standard deviation, sample size also is mentioned, standard error of mean is also mentioned, 95% confidence limit is also mentioned, minimum, median, maximum, normality test that I mentioned in my presentation, Kolmogorov-Smirnov test. whether normality test is passed. Here, see, one group is passing the normality test and another is not. That means in group 1, data is not normal, and group 2, data is normal. So in this case, we can go ahead with non-parametric test. So this is the summary of my analyzed data. Again, I'll click next. It will ask us, you see, it has already selected based on the data, 2 group data, quantitative data. So whether you want to go with unpaired or paired, that we have to decide. So here my data is of 2 groups not related to each other. So I'll go with unpaired, but my data is also not parametric. So I'll choose this non-parametric. So here you can see it has automatically changed the statistical test to Mann-Whitney test. If you see here, if I am assuming that it is parametric, then it is taking unpaired. For non-parametric, it is taking Mann-Whitney test. If I'll go to next, it will show the calculation. Now here we can p-value less than 0.001 considered extremely significant. So you can do it for more than 2 groups also, and even regression analysis also you can perform. So this is very handy software for beginners for doing this basic kind of analysis, and that will actually develop interest in among yourself to have this some interest in biostatistics. So thank you all.
Thank you, Dr. It was
Manish.
really wonderful, Dr. Manish. I've been to Belgavi just recently, and I visited the team also. So I think it is a really nice, wonderful talk which you have given,
Thank you.
especially to beginners, because to understand the data, population, sample, then of course measures of central tendency, then the standard deviations. So standard deviations also, we find it difficult to understand, isn't it?
Yes,
So
sir.
you made it appear simple, and the various tests which can be used to understand the associations, between the outcome and so exposure and outcome, or so just an association. So which parametric, non-parametric, 2 group, more than 2 group. So not very easy to understand. I
Yeah.
think we need to do, and then only maybe we could really understand. So for gynecologists, obstetricians, this statistics is really something which we fail to understand. But it's important, because unless we understand these, simple things about bio, of course, for the complexities, we would like a biostatistician like you. But if we understand simple things, then we probably, when we go through articles or journals, we'll be able to, gain insight into, what is the significance of these articles or journals or research which we are going through, and how to apply in our clinical practice. I think that's very important, and we need to have more such workshops to really understand better. And so we'd like to thank Dr. Gitanjali for this. And over to you, Gitanjali, for further questions.
It was really good, Dr. Manish. Thank you so much. I know you have been traveling and you're really busy. So thank you for taking the time out to help us understand this, rather complex topic. Every time I hear I hear this topic from somebody else, I learn a little bit more. I feel a little better about myself in understanding what exactly is the field of statistics and research. So, and also thank you for introducing that GraphPad is easy thing that we can maybe try ourselves and adopt to the reasonable extent that we can. So thank you very much, Dr. Manish, for such an excellent presentation, and for all the time and all the effort that you have taken.
Thank you so much, ma'am. Thank you. It was my pleasure.
Yeah. Shruti, do you want to?
Thank you.
add
Yes,
anything?
ma'am.
Yeah.
Thank you, sir, for that very much informative talk. I think we should close the webinar with word of thanks by Gitanjali, ma'am. Thank
Yeah,
you.
so I just want to very briefly say that it was such a wonderful presentation by everybody. The expertise that we had across the field were like just phenomenal, and we learned so much. And of course, there's so much more to learn. We can imbibe just so much from all the experts that we heard. So thank you for all the beautiful presentations from all the speakers tonight. And I also thank Dr. Jaideep Tang, Dr. M.G. Hiremat sir, Vidya Topi madam, Sharmila madam, Surekha madam, Rajeshri Palleti madam, and all the leadership of Kasoga and Foxy for being there with all their support and all their guidance at all times. And it really gives a boost to the youngsters like us, and of course the young budding researchers, to do better and better and to conduct more such activities. And I thank all the learned speakers today for sharing their expertise and their knowledge with us. And special thanks to Mr. Arun, because he has taken us through the evening, and not only, and I would literally say he has worked day and night for this event. So thank you, Mr. Arun, for that. And Surekha madam, Nayana Hashilkar madam, Manjula madam, Manish sir, Bellet sir, Madhva Prasad sir, all of them gave wonderful presentations tonight. Sharmila madam was here with us for a short time. She shared her expertise and her experience with us. I thank her for that. I thank all the advisors of the Clinical Research Committee at Kasoga. And I also acknowledge all the seniors in the field who are there with us and who show that learning will always be a process that we should imbibe in us. Thank you, Shruti, for the wonderful conduct of the program today. And
Thank you.
yeah. I also thank all the participants. It was a long session, and I realized that it could be overwhelming when we're listening to it for the first time. But as Sharmila madam correctly gave us the advice that you need to take it one step at a time, and your teachers and your guides will always be there to handhold you. And I really hope that all of you made use of this session and will be able to implement some part of it, at least in your upcoming career in research. Thank one and all who participated, and thank you for staying, for the ones who stayed back till the end. And wish you all a very good night, and hope we meet again. In case there are
Thank you,
anybody,
Shruti, and thank you, Gitanjali. I think
yeah.
you also
Thank
have
you,
done a
ma'am.
great job.
Thank you, everybody.
We look forward to more collaborations. Thank you so
Sure.
much.
Sure. Thank you. Good night, everybody.
And please
night.
send the recording, okay? Link for
Yes,
the
ma'am. It's available on YouTube. Yeah, so the link is available
Sure,
on
please,
YouTube. I'll share the
please share the link.
link.
Thank you.
Thank you. Bye-bye, everybody.